national rates of COVID deaths, you can estimate that because of Oregon's policy implementation, that we save 5,000 Oregonian lives compared to the rest of the country. So really quite impressive. There's more work to be done. There's more work to be done in terms of building trust to continue to increase vaccine uptake among Black, Brown, Indigenous communities, rural communities. We got to earn that trust, and we got to reach out, form partnerships. So we're not done yet, but I really want to thank OHA for their great work, and just take a moment to reflect as we, also turn to other challenges. We saw enormous heat wave with 63 deaths of Oregonians related to heat exposure. Climate change is also a major problem which we will have to come to deal with. It will also exacerbate inequities that are long entrenched throughout the state. But this, I think, as we face other challenges, just to thank OHA for Pat, the governor, Dean Silander, the whole OHA team for great leadership over the last 16 months. Now let's continue with the meeting. We'll vote on the minutes for June. Do I receive a motion to approve the minutes?
I move to approve the minutes.
Okay, a second.
Second.
All in favor? Aye.
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 Any opposed? And any abstain? Okay, great. We have a couple of announcements early in the meeting by our members. Announcements by Jessica Gomez and John Santa, who have messages they'd like to share with fellow board members, OHA staff, and the meeting participants. Jessica, would you start, please?
Absolutely. Just want to say thank you. I'm excited to be on the board. As many of you might be aware, I announced a candidacy for statewide office in 2022. And I wanted to acknowledge the fact that state resources cannot be used to support campaigns, and be pretty explicit about the fact that my work here on the board will be completely independent and separate from any of those efforts associated with the campaign. And just wanted to, again, thank you all for having me.
Great. Thank you, Jessica. And John.
Yeah, I have two things. First, I appreciate a moment to mention the passing of Grant Higginson. Grant served the state of Oregon for 25 years, including 11 years as state health officer. Grant was a deeply caring, sensitive, really good fellow who took his work seriously. I was fortunate, I was on the private side to collaborate with him over the years on multiple projects: AIDS, immunization, fluoridation, and emergency readiness. We had wins and losses, but Grant pressed forward in either case. He was a mentor and a friend. He made me realize that doctors like me on the private side have patients thanking us every day. But doctors on the public health side save many more lives, as we just heard, and often get criticized for their efforts. Oregon has been served well in my time by extraordinary public health doctors at both the state and county level. Larry Foster, Jim Sampson, Grant Higginson made taking care of AIDS patients so much more effective. And those who've served since Grant include that kind of performance. Their work should be appreciated and remembered. Second, moving back to the real world, metrics and scoring will be making final decisions on the list of incentive measures for 2022 in July. The kindergarten readiness measure is on the list, as is the interpreter language access measure. However, two measures currently incented are proposed for removal from the incented list. One focuses on the prevalence of cigarette smoking. The second is a disparity measure. It focuses on the emergency department utilization for physical health issues among members with mental illness. Remember that people with mental illness have a much shorter lifetime than those who don't. And this measure seeks to reduce that using emergency department visits as an indicator that they aren't getting the physical health attention that they need. OHA favors keeping all the current measures and adding the kindergarten readiness measures. Metrics and Scoring also discussed returning the measure for colorectal cancer screening that was deleted in 2020. Concern was raised that performance in that measure has declined, and in the last year, equity concerns have been raised in this area. When measures are removed, they are done so with the promise that if performance declines, they'll be considered again for incentives. OHA will be presenting additional information on these issues at the July Metrics and Scoring meeting. So as is always the case at Metrics and Scoring, we'll have an interesting meeting in July. Thank you.
Thank you, John. I appreciate you bringing that to our attention. Just want to underline the importance of both the mental health measure as well as a smoking measure. And I think those are really very important measures. And smoking remains the #1 preventable cause of premature death. And while it's, it's not new, it's still an important problem. So thank you, John, for bringing that to our attention. Any comments from the board? So let's talk about today's meeting. Today we will have 2 public comment sections. One will specifically focus on the waiver. Will occur just prior to the waiver discussion. And then at the end of the meeting, we will have a second public comment section for all other public comments. So we can focus on the waiver comments as part of our deliberation discussion of the waiver. High Talk will also present their membership board for our approval and our vote and approval. You will also see in your packet the 2021 Q2 committee digest reports that reports all the progress from all the OHA subcommittees. I ask you to look at that. And that will be the focus of our meeting. So I'd like to turn it over to Director Pat Allen for a few for OHA update.
Great, thank you, Chair Bangsberg, and thank you for your very gracious comments at the outset of the meeting. I think a lot of people have worked really hard over the last year and a half, really, that we've been engaged in this. I do think the other important group to thank, though, for their work are average Oregonians. People who wore masks and got vaccinated, businesses that suffered through shutdowns, kids who missed school, teachers who learned how to do remote learning, parents who learned how to do remote learning. A lot of people made a lot of sacrifices that were very, very hard. And without those sacrifices, I think we wouldn't have gotten to where we've gotten. So I want to make sure we thank average Oregonians who have done so much over the course of the pandemic. Few things to report on today. As you observed, we crossed the 70% of adults vaccinated threshold on, I think it was announced by CDC on Saturday with data that we had in hand on Friday. I haven't seen today's CDC update, but I believe we're sitting now at 70.1%. We are committed to moving that number to 80%, and in particular, focusing on getting 80% of communities of color vaccinated by the end of August. That's an extremely ambitious goal. But I'm really proud of the fact that if you take the gap we had between communities of color and white Oregonians that existed at the beginning of April, we've actually cut that in half by now. And right now, the week-over-week growth in vaccinations in communities of color is double the rate that it is for the white population. Now, they're both low numbers. I've used the analogy, it's a little bit like watching 2 semis try to pass each other on the freeway, where it's happening, but it happens slowly. And so we've still got a ton of work to do. But the tools that we're using and the way we're engaging with community organizations and with communities is effective. We just need to be able to continue to sustain that focus. And this is really going to be, I think, a balance of the year effort to get that vaccination rate up. And the reason it's really important is because the vaccines continue to be very, very effective, even in the face of the Delta variant. People being fully vaccinated continue to have a very high rate of protection. It's important when you see data go by to pay really close attention to the endpoints that are being described in the data. There was some news out of Israel over the weekend talking about the effectiveness of the Pfizer vaccine declines to 64%, I think was the number. But the endpoints they were describing were infection and symptomatic cases. which is different than what most data points at, which are serious cases and deaths, and the rates are much, much higher. And so these are still really good numbers for effectiveness of the vaccine. And so the best thing people can do continues to be to get vaccinated. And that's especially true given where we are in terms of eliminating mask mandates and distancing and most of the other non-pharmaceutical interventions. Also really concerned that we have a really good statewide number, but that's made up of outstanding numbers in some places and really very low numbers in other places. I'm very concerned about places like Douglas County, Umatilla County, where the vaccination rate is really, really low. And that if you kind of run the numbers in terms of how many cases we're seeing and realize that those cases are concentrated almost exclusively in people who are unvaccinated, that means that the pandemic amongst the unvaccinated is about as bad as it's been through the entire pandemic, and that's terribly concerning. We have changed a bit of our posture as an agency now that we've crossed over the 70% threshold, but it's really not so much based on activity as it is based on sort of public interest and data. So we have stopped doing our weekend and holiday data reporting. On weekends, we've always done a little bit less, but now we basically have stopped doing any of that reporting, and we'll do catch-up reporting on the day following the weekend, or in this case, a long weekend. And really, it's basically to give folks a little bit of a rest. It actually takes a surprising number of people working through a weekend to be able to do those reports that we generate on Saturdays and Sundays and holidays. And so we'll be able to dial that back a little bit and really allow that resource to be used, I think, more productively for the real work of getting people vaccinated and continuing to address outbreaks and those kinds of things. So that's really a little bit of a thumbnail of where excuse me, where we sit in the pandemic right now. Second topic to talk about, just briefly, because you're going to get a fuller report on it, is the conclusion of the legislative session. This was, pardon me, I think I would say a legislative session, like sort of a once in a career opportunity. Not only did we get everything we asked for, and more of some things we asked for than we asked for, we got things that we didn't ask for that are also really, really good ideas. We got, I haven't been able to quite total it all up. It's at least $750 million of new investments in behavioral health, public health modernization, health equity, all kinds of health insurance coverage. A couple of examples just to illustrate, I think, the scope of what we're talking about. In terms of coverage, we included in the governor's budget a little tiny pilot that we called Cover All People. And the idea was to take the concept of Cover All Kids, which provided kids with Oregon Health Plan-like benefits, regardless of their immigration status, and expand that to basically all people. And at $10 million, that was a really small pilot that we would try to figure out how to go about doing that. The legislature expanded that to $100 million, which is far beyond anything that we thought would be achievable. And the really interesting part of this is the way they asked us to figure out who to cover. Typically, the legislature would tell us who to cover, or they would give us some parameters and expect the agency to go do that. But what the legislature said was, you go engage with the community that's going to benefit from this, and they'll tell you who to cover. And that's a huge sea change in terms of health equity and engaging with community and having community be the ones to, if you think about your definition of health equity involves allocation and reallocation of power and resources, that's the reallocation of power in decision making being demonstrated there. The second example, public health modernization. We've been trying to crack this nut forever. And you'd go to the legislature and sort of have a theoretical conversation about what public health modernization really meant. Well, it turns out there's nothing quite like a pandemic for people to all of a sudden get what public health modernization is. Typically, we'd sit there at the agency and think, well, maybe if we ask the governor for $30 million, we'll be able to put 20 in the budget. And maybe the legislature will give us 5 or 10. And they ended up giving us $40 million for public health modernization. So again, just a huge sea change in the ability to invest in what we're doing. Holly Heiberg will report in more detail on the session overall here in a little bit. A couple of other topics. I've been talking to people about the fact that now that the pandemic workload has changed and is moving out of crisis mode into ongoing management mode, I've been able to go back to some of the crises that were there before the pandemic, and behavioral health was the #1 crisis before the pandemic. It continued to be a challenge during the pandemic, and it's if anything, it hasn't certainly improved over the course of the pandemic. Workforce right now, I think, is the #1 issue. Providers all across the state are reporting dramatic challenges with being able to even use the beds or treatment slots that they have now because of staffing shortages, upwards of 50%. Of who they could be employing to do work to treat people with mental illness and substance use disorders. And so that's really kind of become one of the top issues, again, in the agency that I'm focusing on. Last thing I'll talk about just briefly is the heat wave from last weekend. Chair Bangensberg, I think the number you had was close to the Multnomah County only deaths. So it's actually pushing 100 deaths. And I say pushing, I think people sometimes mistakenly think that we've got some sort of a real-time way to monitor death generally, or death from a particular cause, and it's actually not quite as elegant as that. Local county medical examiners, of which there aren't nearly enough, have got the ability to monitor things in kind of semi-real time. It's a couple of days. But if you look at the deaths we report, even in terms of COVID, we're frequently reporting deaths that may have occurred 2 or 3 months ago because we finally got the death certificate and saw that there was a cause of death listed. And it's sort of similar to that in terms of the heat wave. So we're actively gathering data right now about deaths so that we really can say something about what happened, who it impacted, where it impacted. There's some amount of anecdotal evidence out there of some circumstances, but we really want to know things like, where were the deaths geographically? What were the demographics of the people who died? What were the relationships to underlying conditions? Were they on the Oregon Health Plan, and which CCOs were they being served by, and what kinds of work were they able to do? A variety of those kinds of factors to be able to talk about how to be better prepared. And I say better prepared. We weren't unprepared. There was work going on for basically the week before the pandemic to work on setting up cooling centers, waiving COVID capacity restrictions in places where people could cool down, outreach to the homeless encampments and those kinds of things. It didn't help any that after the day after showing in its little weather graphic that it was going to be 119 or whatever they showed the Oregonian. Then the next day ran a story where the headline was, "Will Portland really hit 118 degrees next week?" Probably not, forecasters say. So I think there was a lot of, boy, is it really going to be that hot? And what does it mean to be that hot? I think none of us, certainly I've lived here all my life and have been through the summers of 107 degrees, and I didn't have any kind of a frame of reference personally for what that kind of weather is. So working with the governor's office in terms of response and what we can learn and prepare to improve our response, and then really learn what we can about the fatalities that occurred, and if there are some things we can learn about how to approach that to try to reduce that kind of an impact next time. That's all I've got for today. Happy to answer questions.
Thank you, Pat. Any comments or questions from the board? John?
Yeah, Pat, could you just clarify? I read that Oregon employers are not allowed to require that employees be vaccinated for COVID, or I presume any other condition that they might be at risk for getting in the workplace.
Actually, it's just healthcare employers that are not allowed to.
Huh. So, I remember back to when I was had my practice and my 5 or 10 employees, and so a physician in practice could not require that their nurse, their receptionist, etc., be immunized to COVID.
Or a hospital or a long-term care facility. That's generally true.
Wow, that's a policy that to me seems worth taking a look at in the future.
Yeah, that's a legislative issue with a lot of competing interests.
Sounds like it could be interesting.
Yes.
Other comments or questions?
Yeah, I think it's a question, but I'm sure there's lots of comments in my question here. But you know, I feel like with the heat wave we just experienced, that was a crisis, and it should be seen as a crisis. You know, when we had the pandemic occur, obviously, and we're still, you know, sort of in it, and we're seeing that as a crisis, and we're doing all these new innovative things to respond to the crisis, and you know, we're creating all these investments to make sure that we're prepared for future crises like this. I think that we should be seeing this heat wave as a crisis, and our response should receive that kind of attention and that type of response as well. I feel like we got a little bit of a warning in the winter when we had these extreme, you know, snowstorm as well. So I feel like it's not just going to be on the heat wave, it's going to be also on like freezing temperatures. And I think we're going to experience this more and more again. I think from what I read this weekend is that there were 3 zip codes, particularly in Portland and Multnomah County, where many of the deaths, you know, connected to the heat wave occurred, and they're in East Portland and East Multnomah County. And I think one of those reasons is because of, you know, higher concentrated levels of pavement, and there's not enough green areas to kind of naturally cool down those areas. And then on, you know, we're also talking about health equity zones or equity zones connected to the waiver. I just think that there's like connections here that we should be thinking about and exploring in terms of how we can make investments that, you know, kind of go beyond what we typically think about healthcare. So just curious to know if there's any thinking around that, or how OHA can kind of support with future, you know, environmental crisis like this.
Yeah, I appreciate the question, and the answer is absolutely yes. For a long time, we've had connection, for instance, to transportation plan development at ODOT around the walkability of neighborhoods and the ability for people to get exercise because they're able to actually walk in their neighborhoods and those kinds of things. Connections to State Parks Department around access to recreation and those kinds of things. But it is, you're exactly spot on right. The built environment has a huge impact on health, and Lentz, I think, was one of the areas that was mentioned in the story over the weekend. And, you know, if you know that area, you know, there are not a lot of trees and there's not a lot of green space and there's lots of pavement. And it kind of begs the question, does that mean OHA should be planting trees? Well, probably not. But what OHA should be doing is helping, and I think we are, but I think people's understanding of the importance of it is informing policy decisions by others, and make sure that people have got the health impacts of some of these decisions as high in their thinking as other kinds of impacts.
Thank you. Other comments, questions?
I have another
Oh, please,
question.
yeah, go ahead. Go for it.
And this is connected to sort of your earlier comments about Cover All People and the larger investment that OHA received than you were expecting. So it's really great to hear. I'm really excited about that, and I'm even more excited, you know, that you're mentioning that the legislature is saying, go ask them, go ask who should be covered. So that's great. It should have been happening a long time ago, but we're here now, so that's good. I'm curious to hear how OHA is going to, you know, take these larger investments that you're getting right now as a result of the pandemic and where things are, and actually be strategic about not just building OHA's own internal capacity, but like actually building the capacity of service providers, organizations, folks that are working directly with people as well. I just think that that's such a huge opportunity to not just sort of grow OHA's internal capacity, but use these resources to really pass these benefits into local communities. so that, when you are being told to go ask them, you already have this natural network of relationships and providers existing that can easily give you those answers.
Yeah, that's a really, really good point. And it is one of the benefits. Yeah, I hate to say the benefits of the pandemic. A thing that we learned in the pandemic that we can continue to apply going forward. And in a couple of ways, I'll use a couple of illustrations. The investments we've made in community-based organizations to deal with the pandemic, going clear back to supporting effective quarantine and isolation, testing, later vaccinations, has been a critical piece of how we've been able to deal with the pandemic. And so, clear back in the governor's budget, the public health modernization component included the continuation of the investments that we used pandemic response related money for first. And there were two components to that. One was just organizational grants to help organizations have the capacity to be able to do work and respond. And I think Vice Chair Arana, that goes exactly to your point of, it's great that there are organizations we want to partner with. They have to have the resources and the capabilities, and we have to make those investments for them to be able to partner in that way. We also then need to have the ongoing relationship with them so that we're not sort of parachuting in on a Monday morning and saying, hi, we're here, we need your help. It's that we've had an ongoing relationship and have been doing work together. It's not related exactly to what we're talking about, but right now, public health is working through how are we going to use what we learned in the pandemic, working with community-based organizations to approach the next flu season. Because the same disparities around influenza exist around disease burden, around vaccination rates and those kinds of things. And so what can we learn from the pandemic and apply to how we approach getting people their flu shots? Same general kind of a principle. And then it is a matter of providing resources to actually do the work. And so I think in that case, large amounts of the investment, for instance, are in behavioral health are related to workforce investments. Now, so that's not structure. There is structure at OHA, but that's mostly investments that go out into providers and community to provide more structure. So I think what you'll really see is in fact a lot of investment out in the community oriented toward how do our partners have what the wherewithal and the resources they need to be able to do the work.
Thank you. Any other comments or questions? All right, and let's move on. Appreciate the discussion. We will move on to a legislative update. We have Holly Heiberg here today to talk about a recap of the 2021 legislative session with special focus on OHA related bills.
Good morning, everyone. I think it's been a month or two since I've been with you, and unfortunately, Jeff cannot be here. I know he is the constant for all things government relations, and he unfortunately couldn't be here. And of course, he wishes that he could. So when we last left you, and I think Pat has, or excuse me, Director Allen has already referenced what an amazing session it's been. And we were pretty enthusiastic when we met with you about where things were headed. And I can do a recap this morning. These slides should look pretty familiar to you with a little bit more about budget. We also sent you our end of session summary, which lists out all of the bills that we've been monitoring very closely that did pass. And then as the last time I was here, I would just say, go ahead, ask me a question at any time. I think this goes better as a conversation, or if you're more comfortable waiting until the end, that's fine too. But however you want this, in my opinion, this is a place where we can have a conversation about this session. So with that, we do not need to spend a lot of time here. We've talked about this. This is really your definition. This was the frame to which we began this session, tried to our best to practice what the definition is during session, and we will continue to operate and use this as our North Star as we head out of session and how we implement. And to that comment before, or the conversation right before here, the government relations team working with Director Allen and the executive team for OHA, we are really working to think about how to move resources into community, make sure that there's no step we take forward on implementation without the community. And this definition is really important to that. So I will just say that. All right, we can move on. This is our staff, as you have seen. It has changed throughout session. I will make a small plug here. We will be interviewing this summer for permanent positions on this team, and welcome many to apply. We hope to see a robust group of people apply for this team. So we look forward to that. All right, moving on. I think this is the area we started to explore. Very few decisions have been made the last time we met, or I came to your meeting. And it really was a watershed session. We are, I mean, just look at these numbers on this slide before we actually get into how it's focused on equity. But look at the shift. We moved from 25.6 billion as our service level to 30.2 billion. Just as a reminder, when we started session, we thought we were moving into a cuts budget. And here we are on the other side with massive investments, transformational in the way that they are provided to OHA and community. We can go on and move ahead. The next slide has more detail. So we've talked about these areas that we're sort of clumping these investments in. Director Allen referenced these, and we could spend a little bit of time here. So if you remember our policy option packages, we are right at the center, our top priorities were policy option packages on centering health equity. And included in that was the $6.8 million for health equity infrastructure, which does include 17 positions for Office of Equity and Inclusion. And again, to that point of how do we partner better, some of this is an investment in our staff, but part of it is an investment in our staff so we partner better with community, because we need that infrastructure at OHA to do that well. So that is moving along already. Leanne Johnston is doing a lot of work to organize this and think this through, think about how we're really better partnering with community and using these funds to do that. We did receive both the bill and the funding, which isn't a lot of funding, but it is significant work to have the tribal traditional health worker category, and really supports the foundation of work we have coming across OHA. Julie Johnson will tell you that this is may not seem like a lot in the billions and billions of dollars of change in our budget, but this is again a major change. Oregon will be, I believe, the first state to really move into this Indian managed care entity, and she is already underway in the engagement with this in a meaningful way, and we did get fully funded to move this out, so we're very excited for that. In behavioral health, we talked a lot about this last time I was here. This bucket feels a little hard because some of this is in federal funds, some of this is in general funds. The package as described by Rep. Noss and Senator Lieber that they were moving through was considered to be a $350 million general fund investment. But as you can see, it comes with a lot of matching funds, leveraging federal funds. And then in addition, and this really didn't come to light for much of session, but the legislature outside of that funding also invested $300 million as ballot measure 110 said that they should, but that's $300 million into substance use disorder, co-occurring disorder treatment and services and infrastructure that can be funded through the ballot measure 110 fund. 300 million. That's in addition to the other funding that the legislature made available. I will do my best if you have questions about this behavioral health funding, either now or at the end. We did end up with quite a few really important pieces of legislation. One that I want to bring to your attention is House Bill 2086, which started as an OHA investment bill for programs and services as outlined by the Governor's Behavioral Health Advisory Council. As the conversation continued through the legislature, it was clear that when they made these investments, they really wanted accountability. And so we worked with the legislature and put language in 2086 that really describes what that accountability framework will look like. And we can talk a little bit more about that either today and or another time. We're very excited about it because it gives an opportunity again for community to sit at a table and help provide to OHA and the legislature what success looks like. What does that mean for outcomes? What does that mean for measures? And how we then would put those measures into our contracts, our grants, our expectations to those who provide services. And then on the other side, and this may sound a little bit like how we've worked with CCOs over time, how would we incentivize those outcomes once we have solidified them and put them tangibly in contracts and grants. So that's exciting work, and there's a lot more to come on that. And we, again, that's as Lillian Shirley would say, bigger than a bread box. So perhaps that could be another topic at another time as well, but happy to try to answer questions today. And then I would also say, near and dear to my heart and described here, for public health, we did, the legislature decided to fund $45 million towards modernization. Director Allen described where and how some of that money will be used. Certainly when I hear Director Rachel Banks and Kara Biddlecom talk about this, at the heart of it are our community-based organizations that we are working with already, and moving out more work in more directions, whether that is looking at climate change and how we engage communities, whether it's looking at furthering the work we're doing in communicable disease. This is really going to, it's hard to imagine exactly because it's so much money. I know we've talked about all the money for COVID, but that comes and then it goes. And this is sustainable funding over time, and really an exciting moment for public health in Oregon. Also a large priority for the legislature, and that we began to work on out of the last long session, is universally offered home visiting. The legislature continues to prioritize that work, and public health is moving out on that as well. So those are some of the larger investments that you're seeing here. If you go to the next page, I think we might have, oh, we do not have all of the investments. I will just also touch on these. So as Director Allen pointed out, we're looking at 10 times the investment for Cover All People that we started with that tiny little pilot. That is just really exciting. And overall, this work of the budget in combination with the policy shifts. So when you think about the investment in Cover All People alongside of the shift in how any merger or acquisition will be looked at in the state to center access and center health equity, you're starting to see some really big shifts in the way that people receive healthcare, assuring that they have access. And we are just very excited as we move out and talk to community about what this will look like on the ground. So that is just moving forward, the very a short highlight of a very complex and I will say transformational budget. Maybe I can pause there for a minute before we go into the bills if you have any questions.
I have a question. On the 24 bed expansion for, I guess that would be acute care. How is that money allocated? Is it for just the infrastructure piece? Is it for running an extended sort of service in that area, or how is that sort of spread across the cost there?
So let me ask a clarifying question back. So you're not talking about, were you asking the state hospital funding, or were you asking about the community grant, the community money for residential treatment and housing?
If you go back a slide, it was under behavioral health. It was this to open 224 bed patient units in the state hospital.
Great. Yes. So that money, the $31 million for $31 million it's actually an SRTF capacity in the state hospital. So what we're finding is that there
Your residential treatment facility for those playing along at home.
Oh, sorry. Thank you, Director Allen. So my son calls legislative work the 1, 2, 3s and the ABCs. And if anytime I'm saying something that needs clarification. So that funds those 24 secured residential treatment facility beds. And the reason that was a priority investment for the hospital is because part of our issue isn't just being able to take people up on the front end. The other part is being able to place people when they're ready back into community. And what we've learned is that there are resources in this bucket for residential treatment in community. There will be more in supportive housing in community, but it really helps to bring people back to community if they do have this sort of step down. We can, when they're ready to go, but there's not a placement, we can put them in this SRTF capacity at the state hospital. And it does fund the staff as well as the 2 units. So the 2 units exist, and they're mothballed at the moment, and now that will provide the staffing need to get them stood up and running and moving out. Director Allen, is there anything you wanted to add to that? I feel like you live a little closer to it.
No, I think you got it.
Okay.
Thank you.
Sure. I'll just attach to that, though. It is important, just as you squeeze on one side of a balloon and you don't shift the other, all of these do connect. So as we move out with the residential treatment fund, again, community gets to identify what they need, what are the highest priorities, and then present that to OHA, and then we'll present it to the legislature, unlock funding, and get that money back into community. So we'll learn a lot more in the months to come about what community actually needs to meet their behavioral health individuals with behavioral health needs in the community itself. So we'll learn more. Are there any other questions? All right, we can move on to bills if you'd like. Next slide. I don't think any of this should look new to you. I think Jeff has covered this each time. What is something to take note of is how many things are in blue versus orange as we move through. I don't think we thought in any session to see this many things actually pass. No one expected this. It's pretty amazing, which also does mean we'll have a lot of work on this side of implementation. So be prepared for lots of conversations and thinking as we move through this work. All right, for reducing health inequities in our communities, I will not read this list. We've already talked about quite a few. Of course, modernizing public health is one of the largest priorities. Many of these bills were our fee bills that we moved through and were successfully able to move through the legislature. I will stop on telehealth for a moment. This might come up in multiple settings. So this does allow, taking again a lesson learned from the pandemic, we really were able to move ahead in telehealth and codify in a state law the practices that we had underway during the pandemic. Where it still has a little bit more work that we'll be working on is around if you were accessing telehealth out of state. So this is coming up in different settings. So this bill helps codify telehealth and how it's paid for within Oregon. But we will, I think you will see this again come up because some people are accessing their health providers out of state right now. On this slide, I don't think there's anything else you haven't heard or thought about as the conversation has developed over session. Next slide. And this is a list, and I think this is useful because in our summary, we didn't put what didn't pass, we put what passed because at that point we reached 11 pages of documentation about the session. So maybe I could spend a second here. The reportable disease information, this was a bill, I think we've talked about it, and I think it will come back again. This, there was a lot of criticism of OHA during the pandemic about what information we weren't releasing, weren't releasing. And we worked pretty closely with Senator Denbrough and advocates to try to get this bill in shape. It did take some resources because if we were doing more reporting and getting more information out, the public health division would actually need a little bit more resource to do that. And unfortunately, that did not make it over the finish line, but I do think it'll come back again. There were a couple of fees here that weren't bills, but were policy option packages. We're looking at a different process to get those fees up and running the way that they should be. And I think for the long-term care emergency response teams, there were a lot of good conversations about that bill. Many things could happened or could happen outside of that bill. I am not sure if that's coming back again or not. We'll keep an eye on that. I do think we'll see more for harmful algal blooms. We're doing some things with federal grants, and our partner agencies are also doing work that they can. I think we'll see that again. And certainly we'll see HB 3108 come back. That was Rep. Prusak's bill, and if Jeff was here, he would say that this one is definitely tagged for a future session. All right, let's go next slide. Again, we've touched base on most of these, but I will highlight another big transformational bill, and the funding for it was House Bill 3159, which will allow us over time to collect this REAL-D and SOGI data in a meaningful way across our healthcare system. There were a lot of complaints that I very much understand with the bill we helped pass in short session 4212 that allowed us to gather REAL-D for COVID. We learned a lot from that, and it helped shape House Bill 3159 in a more meaningful way. The resources are there for OHA to put in place the right receptacle for data from the healthcare system, and we will be rolling it out over a period of time that really allows the healthcare system to develop this in a meaningful way. So we're excited about this bill, and of course, really getting to the place where we're moving to collection of SOGI data along with REAL-D is again another transformational moment for all of us. And I just learned that Connecticut has been following along and has adopted similar REAL-D measures. So we'll be reaching out to Connecticut very shortly so that we stay coordinated, and perhaps this becomes something that we're creating momentum for nationally. I think we have talked either at other times or a bit today on most of these. how about I pause and see if anybody has a question about any of the items on this slide.
Holly, I have a couple of questions. Maybe I'll start big, sort of broader scope, and then more down to the specifics. One, I'm curious what you're thinking. I mean, it sounds like some of these investments are, fairly larger than expected and maybe one time in nature as well as a result of all the federal funds that are coming in. Curious to hear about, sustainability elements, long-term sustainability efforts. And then my other more like focused question, and it kind of connects back to my comments or questions that I was asking Director Allen regarding, sort of like extreme climate. I think that there's opportunity with the Healthy Homes program to potentially use that program to make low-income folks' homes more climate resilient. Curious to know more about how that program is being rolled out and if there's opportunities within that program to make, homes, have better AC or heating mechanisms.
These are fabulous questions. Thank you. So on sustainability, I think that is a question that we'll be working with the legislature on over the months to come, because there were a lot of questions about the color of money being attached to various proposals. And in many cases, not all, not many. In some cases, there's still some sorting that we're doing with the legislature to understand exactly what that looks like. And I can tell you that in conversations with Senator Lieber and Rep. Nose, they felt strongly that the trajectory of Oregon and where we're headed, that if we build this work well and we demonstrate to the legislature that the investments are worth making in the cases where they weren't able to fund it with ongoing general fund, that they feel that there is a strong case that they will in the future. And I thought that was rather bold of them to say, but I think that is good. It tells us that if we do our work well upfront, that we can bring that back for more full-time funding. And I think when we talk about Cover All People, that's a really interesting example where the debate was less around where is the money right now, but when and if, as we're able to truly ramp up and cover all people, what will that look like in the next biennia? And it will be in that situation. I think that particular legislation and the way it was formed, the legislature would actually have to come back and choose not to fully fund that in the next biennia. So this is going to get interesting as we move out, right? So if it's $100 million investment for this biennia, and it will become more expensive as we go into the next biennia. Right now, the default setting is that it will be sustained and that it will move forward. But I do think all of this is part of how they decide to choose to fund health. And so we will have those debates coming. They are out there, and we should. That's certainly a good conversation OHA will be having with the legislature, others will be having with the legislature to prioritize the work. So that might not be a perfect answer, but that is sort of where the conversation was left at the end of session. And then on, I think there's a lot yet to be done and discovered in what we can do through the Healthy Homes program as we are just moving out and standing it up. And I will take that back to Director Banks, who I will say on Friday, I met with Director Banks and Gabriella Goldfarb, who runs the environmental health program for public health. And there were questions about how much could be leveraged as we move this out into that exact question about what we can do to mitigate climate change through Healthy Homes program. In addition, it's worth noting there were some conversations over the weekend with our Medicaid director, thinking about how the Oregon Health Plan can provide air conditioning, just something as simple as air conditioning through CCOs. And it is my understanding that that is possible. So, you know, there are various ways to which that work can move forward. And I see Director Allen has more to say.
Yeah, well, I was just going to jump in before everybody gets all excited about a massive expansion of air conditioning. It's worth pointing out that nighttime temperatures in Phoenix on average are 3 degrees higher because of all the air conditioning. And so some of the stuff that Vice Chair Arana was talking about earlier, trees and green spaces and better insulation in houses and those kinds of things are also effective ways to help with cooling that don't actually add to the problem.
Holly, we're approaching time, so we should
Oh.
keep on moving, please.
Sounds good. All right, well, let's move on to the next slide. Again, I think you know all of the pieces here and what didn't pass. I will note COVID dental. Really, that didn't pass, but we think we have this covered. So back to you if we don't have it, but I think we've got this between federal changes and the monies that are allotted. So I think we have this covered. Next slide. And again, we've discussed behavioral health earlier. We will be working throughout the summer to begin standing up the infrastructure that really will help move some of this forward. And we'll be happy to connect with you again on how we're moving this out. Next slide. And again, this is the remainder pieces. Behavioral health among these areas was really, there was very little left that wasn't addressed with funding. It was quite an incredible moment. And next slide. Oh, good. So just to sort of wrap in what we have been talking about, we're moving out right now. We're trying to be thoughtful. Met last week already with the Office of Equity and Inclusion, and we're talking to our community outreach programs about what it will look like to now move into implementation of bills and how to connect. I think we're trying to get ahead and start thinking about this. What does that look like? When we came to 2021, we had a bunch of ideas, and then we brought them to community partners that we have been forming or had good relationships with. We want to look at that differently for 2023 legislation formation and actually come to community first. And so we're trying to figure out how to do that in a meaningful way and how to do it soon, because believe it or not, you have to start that cycle pretty soon. And then we're also starting to think about how we more formally codify community input and engagement as we do our own bill analysis as bills are moving through session. So these are the ways we're thinking about as a GR team, a government relations team, as shifting our work. More to come. We got a lot of work to do. We learned a lot this session. It is certainly not, the legislative process is not the place to have deep conversations, build the trust, and come up with ideas together. And that work needs to be done now before session begins. So we're trying to learn from this session and begin again at a fresh cycle and think about how to do this work differently. And that is really it for what we have today. And if there are any final questions.
Congratulations on this progress. Any comments or final comments or questions from the board? All right. Well, thank you, Holly. I really appreciate the presentation. Hope Jeff feels better. And I want to check in to see, we have a few people on the phone. I want to check in to see if Ebony Clark has joined us. Ebony, are you on the phone? Right. We will now move on to the Health Information Technology Oversight Council proposed membership slate. Today we have HITALK staff and the HITALK staff, Susan Otter and Hope Preskin Shepherd, along with Kirsten Isaacson, our OHA Oregon Health Policy Board member and liaison to HITALK, here to present the membership slate for us to discuss. A few minutes, we'll have time to discuss this at the end, and this will then lead to a vote for approval. So I'd like to hand it over to the HITALK group.
Great. I think I'm going to kick it off. Is that right, Susan?
That's right.
Okay. So it's been such a pleasure to be the liaison to HITALK since joining the board. And I think a lot of the work of HITALK can sometimes be understated in the background. But the truth is that we as a board really can't meet our goals without HITALK and all our committees doing the incredible work and carrying incredible loads that they do. And I think HITALK is coming before us at the board today because they are not at capacity and need new and to renew committee members in order to do their important work. And they support the technology needed for our care coordination, among other things. And a lot of that work right now in the months to come is updating HITALK's strategic plan. I think it was a little fortuitous that HITALK wasn't able to do that. Like that work had started to ramp up, and then the pandemic hit and was paused because staff needed to put their dedication elsewhere for a while. And maybe that was a good plan, because now it is important that we reassess in this major effort, listen and engage a broader group of stakeholders, and then create the strategic health IT plan for our state. And part of what that includes is a focus of social determinants on health. And specifically when I think about how HITALK relates to SDOH is around our community information exchange, which is succeeding in several parts, or is maybe not succeeding quite yet, but taking hold in different parts of our state. And I think, reading through our prep materials on the waiver concepts, like this notion of the community information exchange is a technology platform that we're going to need to support our waiver work. So I'm excited to support the slate in front of the board today. I really appreciate the considerable work that staff work that went into, not just staff work, but also committee member work that went into recruiting the slate before us today. And I think that there will certainly be more to learn from the board's committee membership study that will come before us, I think in August. And it will evolve in how we learn and improve our success with recruitment and retention in our committees and boards. But I think that staff did hats off to Susan, Hope, and others, an incredible job to bring us this slate today. And I think demonstrated a lot of kind of wisdom in holding some vacant seats to continue to work to improve diversity on HITALK. But yeah, take it away, Susan and Hope. Tell us about the slate before us. And I'm thrilled to recommend it.
Thank you so much. As Dr. Bangsberg mentioned, I'm Susan Otter, Director of Health IT for the Oregon Health Authority. And I'm joined by Hope Peskin Shepherd, who's an analyst supporting our HITALK committee. So I want to give a little context, and then we'll talk about the work we did to develop the slate. I hope everyone's had a chance to review the slate. It's in your packet, as well as on the last page, we include the demographic breakdown of the proposed full slate of HITALK, as well as comparing that background to the current HITALK members and the demographics for the state of Oregon. So I know that's something that we'll be talking more about as we get into the committee membership, improving committee membership for board committees, but wanted to refer you to that. So HITALK was established in 2009 by the Oregon legislature to ensure that our health system transformation efforts are supported by the right health information technology, including an early focus on electronic health record adoption, supported by federal incentive payments that went to all Oregon hospitals and a huge number of providers in Oregon to adopt certified electronic health records, as well as to explore how best to connect systems, share patient data across differing systems, CCOs and healthcare providers and hospitals who are treating the same patient and need to coordinate their care. HITALK's responsibilities are set out in the statute as well as our charter. HITALK's responsible to set the strategic plan for Oregon around health IT and to explore and monitor policy related to health IT, assess the landscape of health IT, including the adoption of electronic health records and the state of health information exchange, and report on progress. And then HITALK has an oversight role as part of our OHA's health IT efforts. The main focus, as Kirsten mentioned, and coming up is to update Oregon's health IT strategic plan. That will include considerable stakeholder engagement, listening sessions, and we will likely have 1 or 2 work groups under HITALK to focus more intently on the concepts of community information exchange and the next stages for health information exchange. Next slide. I'll go ahead and forward through all of the, one more, there you go. So, thanks. So our current strategic plan was established in 2016. It was a 2017 to 2020 strategic plan, and it set forward 3 health IT goals that you see here and identified an emerging area for health IT at that time around social determinants of health and health equity. We know that those areas are going to be a major focus for our next strategic plan. How do we use health IT to support our goals in achieving health equity and supporting addressing social determinants of health? The core goals that are in our current strategic plan focus on sharing patient information across the care team. We've made great progress in the last 5 years in health information exchange, including recent successes in sharing COVID case data and COVID vaccine data through health information exchange infrastructure in Oregon with providers and CCOs who need to take action on that data. So that's just one example of some of the successes we've had that we've seen. The second goal relates to the need to use data and technology tools for system and quality improvement, supporting value-based payment, including the collection of quality metrics, and cost containment efforts. So that includes tools related to managing populations, being able to, for example, identify risk factors across a CCO's population or a primary care home's population, and be able to target interventions using the power of data and technology tools. The third goal relates to patients and consumers or their families being able to access their own health information and collaborate in their care. In the past, we've seen this largely through patient portals that are attached to a provider's electronic health record. You all may, be familiar with logging into MyChart, for example, and being able to message with your provider or look at your full clinician notes now in many cases. This area is expanding with new federal policy that really is promoting patient apps or consumer apps and being able to connect the app of your choice to your provider's electronic health record and download your data. So this will also be an area where we'll be focusing in on how do we leverage those new federal policies to improve our patient health in Oregon. Next slide. some of the challenges that we've seen in health IT that we need to be addressing as we look at this next strategic plan and HITAC's work overall are that electronic health records still face major challenges in talking to each other and sharing that information about patients that a provider or CCO has in common. We see a particular challenge around behavioral health. Just looking at the legislature's huge investments in behavioral health, there's a real lack of high quality electronic health records for behavioral health providers in Oregon, and that impacts not just in Oregon, but across the system, the industry. And that impacts the ability for behavioral health providers to share information or participate in care coordination, as one example. COVID-19 showed the need for better connected systems between the healthcare system and public health and community-based organizations. We've learned some great lessons in being able to share, as I mentioned, COVID-related data, and are taking those lessons and diving into some deeper work to identify where can we learn from that and move forward in the future and leveraging health information exchange or connecting to public health. And then we see new opportunities for connecting healthcare and social services, which I'll talk about in a minute. As I mentioned earlier, we have changes. Recent federal health IT rules have changed the incentives and penalties around sharing health information. So there's they're called the interoperability rules, including penalties for information blocking. So it really puts different kind of pressures on the healthcare system and payers to have the right to share that information to better inform patient care or to make information available for patients through a patient app, for example. As we look at House Bill 3159 that passed related to RealD and SOGI and expanding RealD and SOGI data collection from providers and health plans in Oregon, we face a challenge today with the federal standards around race, ethnicity, language, and disability that are built into electronic health records don't necessarily align with the state RealD standards. And so we see a real opportunity. We've learned a lot of lessons with collecting RealD data for COVID purposes, and look forward to having HITAC play a role as we roll out 3159 more broadly. And then lastly, a challenge I wanted to highlight was the federal incentive payments that I mentioned earlier around electronic health record adoption. Those are sunsetting later this year. Those payments and that federal funding has allowed us to invest in our state health IT programs, staff, new incentives, et cetera. And so those federal funding opportunities are ending. So we'll be transitioning our state funding to different federal match, which required new state funding to be invested this year. We received some of that funding, but we will be ending some of our programs that were not funded due to other priorities. Some of that was planned, and some of that is that we are now planning around. So HITAC will be helping us as we oversee this transition to less rich federal funding, really, around investing in health IT. The last thing I want to highlight before we jump into the slate was the spotlight on community information exchange that Kirsten mentioned. So CIE is a network of healthcare and human or social services partners that use a technology platform to connect people to social services and supports. This helps efficiently search for available social service resources and make referrals, and be able to track those referrals or close the loop in many cases. So you can see a CCO or a healthcare provider really make a referral for housing or transportation or food. And then hear back when that loop is closed, that social service agency in many cases can log that they have filled that need for that individual. So the provider or CCO or other person can track that was closed. There's great value in community information exchange, including connecting individuals to better culturally and linguistically specific services, coordinating more easily across organizations, improving efficiency and reducing time to service. And then overall, looking at the data that CIE collects to look at which referrals, types of referrals are being made, where do we have referrals for social services that are not being met, and can help put data behind the gaps that we know are out there in the social service sphere. So these community information exchange platforms are spreading across Oregon due to investments by CCOs and other health systems. And this brings an important infrastructure to support some of the Medicaid waiver priorities. We'd love the opportunity to share more about HITALK's work, including CIE, in potentially an informational webinar outside of this meeting, but I wanted to give you a taste of some of the work that is on HITALK's plate. Next slide. Okay, next slide. So as I mentioned, we're asking the board to deliberate and take action today on our HITALK proposed slate. This is in the context of the policy board's work on committee membership. That work was really tasked to OHA last fall when the policy board recognized the need to improve diversity in both committee recruitment and to address committee retention as well for the policy board's many committees. That work has now been charged to a consultant, and I have recently taken over, just coincidentally, the lead staff role as others have needed to focus on the waiver and other priorities. So I'm very closely involved in that work, and it's been an interesting experience going through the HITALK recruitment effort, knowing that these recommendations will be coming to the board in August with a preview at a July 13th informational webinar. So I look forward to that conversation. We are recruiting for HITALK, or we did recruit for HITALK early because of the urgent need to fill our vacancies, given the priority work ahead. We recognize that we hope there will be structural changes that will come with the recommendations to the board. We're already considering, OHA is already considering how do we better centralize and standardize some of the committee recruitment processes so that we have less of the one-off rush to identify and build relationships and develop slates as kind of committee by committee. Our slate recognizes that we did not meet our goals of filling all gaps, and so we are leaving seats open for additional recruitment that we'll be doing ongoing. So I'd like Hope to talk a little bit about the process we went through very briefly, and then we'll talk about the slate.
Thank you. If you can, bring up all 4 of these steps. So there were 4 major steps in our process, and we consulted with the committee membership. If you can press next, please. We consulted with the committee membership work group 3 times during our recruitment process for feedback and guidance on our process. And I'm going to jump right into our first step, which was our gap analysis. If you can press next, please. And one more time. Thank you. Can you press next, please? So with the gap analysis, we wanted to take a look at all of the areas of expertise, knowledge, experience, and representation that go into the makeup of HITALK and factor that in to our gap analysis. So with the green, we started with HITALK's governing documents, which are the statute, charter, and bylaws. And the statute requires HITALK to have 4 main areas of expertise, knowledge, or direct experience in healthcare delivery, health information technology, health informatics, and in quality improvement. The statute also requires a broad mix of individuals and organizations impacted by the work, and this is outlined in more detail in HITALK's charter, which is represented here in blue. So you can see a number of different individuals and organizations represented here. For example, the charter requires subject matter experts making up a whole person care perspective, as well as individuals and organizations that work with populations experiencing systemic inequity, and also geographic diversity from around the state. In addition to these required areas in the orange here, We also looked at additional representation needed based on upcoming priorities, such as the strategic plan update. And we also used the Office of Equity and Inclusion gap analysis tool, which was provided to us by the committee membership work group. And this tool focuses on race and ethnicity and geography. And we also incorporated other demographic areas from the OHA definition of health equity into our gap analysis. And through considering all of these aspects and crosswalking with current membership, as well as having conversations with HITAC members, the HITAC chairs, Kirsten, our liaison, and OHA staff, we identified a number of priority recruitment areas. Next slide, please. So through this analysis, these were the gaps that were identified, which include several areas integral to whole person care, health system transformation, and building toward a more connected and more equitable health system. And these gaps informed our outreach. Next slide, please. So I just wanted to share some highlights from the outreach that we engaged in. We had, I would say, 2 waves of communication outreach. The first stage of communications was more of a sharing of a broad announcement. And so we reached over 25,000 Mass General mailing recipients, for example, from the Office of Health IT's email list, as well as contacting multiple types of provider associations, including regional dental societies, for example, and the Provider Matters newsletter, clinics, and OHA committees. We also worked with OHA staff to share with over 750 community organizations through the Community Partner Outreach Program, the Community Engagement Team's COVID-19 grantees, and through the Regional Health Equity Coalitions, as well as reaching out directly to 12 community organizations. We also shared the announcement with now approximately 30 individuals. And of these, we engaged in one-on-one recruitment of now 17 priority candidates, which included personalized email outreach, an additional follow-up, and meeting with 6 people. Thank you. So this is just showing that currently HITAC's bylaws require 11 to 15 members. The proposed slate includes 4 current members, 5 members that we are requesting to renew, 5 new members for a total of 14 members, leaving 1 seat open. And we've also had discussions about expanding HITAC's membership, which HITAC's chairs are supportive of. And sorry, that's in the HITAC's bylaws, so HITAC would be able to vote on that. And now I'm going to turn it back over to Susan.
Great. So I wanted to just highlight things about our draft slate. And
Susan, you're having a little bit of internet trouble.
Phil's. Oh, uh-oh. Can you hear me?
No,
Am I back?
You're back.
Okay. Okay. Sorry. So this fills most of the gaps that we identified from oral, academic, public health, and social determinants of health gaps, increases the LGBTQ diversity, and maintains our gender and regional diversity. If you go to the next slide. We do have continued gaps around behavioral health. We have our behavioral health members expected to planning to roll off at the end of the year. And we lack representation from Latino, Latina, Latinx, and or Native Hawaiian Pacific Islander communities. We will continue recruitment and aim to fill those remaining gaps by the end of the year and leverage the recommendations of the committee membership work. Next slide. Thank you so much. Look forward to your questions or any comments.
Thank you for the summary presentation. Let's open up for comments and questions from the board.
I just want to say thank you so much for this really thoughtful process that you've led, and sort of like, you know, being so intentional about potentially not completely filling up all the spots because you're noticing that there's still some representation that needs to be included, and the idea of expanding the committee as well. So I just, I'm really glad to see this happening. It should be, you know, I'm kind of hoping that it becomes a standardized process across all the committees. And I feel like you guys are really setting the bar this way. So I really appreciate all your work and attention to this. And, you know, also really enjoy seeing the data, not presenting on the slides, but on our packet, the data in terms of like kind of that baseline and the new information with the new slate. I think it's really important to measure that progress as we move forward, so we can kind of look back and really see the progress we've made in these areas. So thank you.
Great. Thank you. John?
Yeah, impressive. Just really terrific. Love the slide that summarized all the outreach efforts. Just really impressive. Thank you.
Jessica or Bill, any thoughts you want to share before we move to a vote?
Not for me, thank you.
Great. All right. Also appreciate the thorough work and presentation, so thank you very much. So do I hear a motion to approve the board slate as presented?
So moved.
Second.
Okay. All right. All in favor, aye.
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 Any opposed? Any abstain? I think Ebony, she had a conflict and wasn't able to join us, but let me just double check. All right, fabulous. It's just before, it's 10 o'clock, 10:01. We're scheduled for a short break, so we'll have a 10-minute break. We'll come back at 10:10 to discuss the Medicaid waiver update. So thank you all. Health Policy Board. We will move on to public comments regarding the Medicaid waiver. And we have one comment from Courtney Johnson. And just as a reminder, we really very much appreciate public testimony. We want to listen very carefully, and that in the deep listening we will provide means we won't respond to what you share, but Vice Chair Rana and I and the OHA staff discuss each comment in our weekly business meeting. So we will listen carefully. We look forward to your comment. Appreciate you sharing your comments. Each presenter is giving 2 minutes to share. This often doesn't feel like enough time, but we want to make sure we proportion the time out for public comments to get as much public comment or testimony as possible. Please also know that any written comments are also reviewed by Vice Chair Rana and OHA staff, and the board staff will communicate any follow-up with the public commenter. So I'd like to welcome Courtney Johnson, representing the CC Oregon's letter to the Oregon Health Policy Board.
Thank you. Good morning. So my name is Courtney Johnston. I'm the Senior Director of Medicaid and Government Relations for Trillium Community Health Plan. And we are a coordinated care organization serving Lane, Western Douglas, Multnomah, Washington, and Clackamas counties. And I am, as you noted, speaking here today as a member of CCO Oregon, which submitted comments regarding the next 1115 Medicaid demonstration waiver. So CCO Oregon represents coordinated care organizations and provider partners responsible for delivering the Oregon Health Plan benefit to Oregonians across the state. You heard from other CCOs at your last meeting in June and our initial comments. And since then, CCO Oregon has convened CCOs and our provider partners to review the OHA's concept papers and make recommendations and comments more specific to those proposals. So first, let me say we really appreciate the work OHA has put into their proposals, especially on finding ways to leverage our savings and advancements in quality to continue upstream investments. You have this comment letter, so I'm not going to review it in full, but there are a couple of things I want to draw attention to in my comments. Pharmacy costs specifically. We know that over the past waiver demonstration periods, CCOs have successfully managed costs within our control below the 3.4% rate of growth, but some healthcare costs are difficult for individual CCOs as well as the state to control. Most prominently, the rising cost of pharmaceuticals will continue to pressure CCO budgets and take resources away from other community investment opportunities. So finding ways to relieve that pressure so it's not disproportionately impacting our reimbursements and allowing us to create community investment opportunities is imperative. Secondly, I just want to draw attention to oral health. As you all know, the CCO model is centered around whole person care and the importance of improving our oral health delivery system and ensuring an equity-focused oral health model needs to be elevated in this conversation as well. And then lastly, workforce and infrastructure. Overall, we've been really pleased to see the Oregon Health Authority and the legislature's focus on addressing barriers to care in the behavioral health system, but we know that workforce and infrastructure across all provider settings needs statewide resources and attention. In many cases, our workforce is in crisis levels, and I bring this forward today because we want to ensure that as you're reviewing the OHA's proposals today, we're thinking about them in the workforce and infrastructure with the workforce and infrastructure needs in mind. And again, this is imperative that we address these gaps in the delivery system in order to advance our transformation goals successfully and sustainably. We are excited about additional coverage opportunities the OHA has proposed and their impacts on the quality of care of our members. You'll note in our letter, we have suggested coverage expansion opportunities as well, including postpartum and pre-education coverage and state hospital coverage. We are also continuing to engage in the stakeholder processes that OHA has created and partner with the state to share our feedback at every opportunity the OHA is allowed. So I guess with that, I hope I stayed within that 2 minutes. So I'll thank you for allowing me this time today and for your work, helping to drive this important work.
Thank you very much. I think our timer stalled there for a minute or for a second, but that was very well done. Thank you for that comment. And we will move on and welcome Lori Coiner and just Jeremy Vandehey, who will update us on the Medicaid waiver update.
Great, thanks. Lori and I are going to tag team a bit. I'm going to kick us off. We're going to tag team a couple of the policy areas, and then Lori's going to close us out with a specific conversation. We wanted to deep dive a bit into one part of the overall set of waiver proposals, which is changes to the quality pool program moving forward. So as we go through this, we'll give a quick recap of the waiver process, what it is. Want to share with you today some of the feedback we've received so far in the process. And then, as I mentioned, we'll have a strategic conversation around the quality pool. Next slide. I think folks know, but just a reminder, each year, we have to renew our Medicaid waiver once every roughly 5 years. We've had a waiver going back to 1994. The waiver does not define our entire Medicaid program, but it gives us an ability to do some things differently outside of what federal law normally allows for. And in agreement for that, we agree to a set of terms and conditions for how we'll make sure that we preserve quality and access, and how we'll generally operate the program with that additional flexibility. And we have to renegotiate those terms every 5 years. Think about this a bit like this is kind of a final step of implementation of CCO 2.0. The main step of that was going through a procurement, and now is our opportunity to see if we can get some additional federal flexibility to take the overall vision and direction even further, and then that would sort of tee up where we go with the next CCO contracts down the road. Our current waiver expires next summer. And we have to apply by the end of the year this year, and then the first half of next year was really a negotiation process with our federal partners. It's an interesting time to be going through this because we are in midst of a change of administration with the federal government, and have been waiting for some key seats to be filled, both the CMS administrator as well as the Medicaid and CHIP administrator, and both of those seats have now been filled, which is great because the timing's perfect because it's right now that we literally need to start having conversations with CMS, and have been in somewhat of a holding pattern as we've been waiting for a couple of those spots to be filled. I want to go to the next slide. So overall, where we've been to date, we've been on a fairly compressed timeline, given everything that happened this last year with wildfire and the pandemic. The process we've gone about generally has been really to start with all the feedback we've received as an agency the last several years through a variety of different strategic planning initiatives, being CCO 2.0, the statewide health improvement plan process, a variety of other places where we've been getting community input, and really started from that spot. And so I've been going out to get input really on some initial direction that we've taken from those various input pieces. And so we started with summarizing input we've received over the last several years. We've developed out of that 4 concept papers that were in 4 priority areas or focus areas. Those concept papers were released around June 1st, and we covered those with you at the last board meeting. Since then, they've been out for public comment. We've been making rounds with a variety of committees, specifically the Health Equity Committee of the Policy Board, the Medicaid Advisory Committee. We've also had some standing work group meetings between with some legislators who've been assigned by legislative leadership to work with us on waiver, with CCOs and provider organizations. And so I've had a variety of places we've been getting feedback throughout the last month. We've also done 2 waiver days. We're called the waiver days, sort of online town halls, if you will. We did one in end of May, and then we did a second one in June. I think we had about 200 to 300 people attend the first one, and I think close to about 100 people attend the second one. The second one was also after hours. It was from 5:30 to 7:30, so that we could make it more accessible to folks. Our next step in this, after providing some summaries on the feedback we've gotten to you all, is getting feedback from the board today is going to be a second version of these concept papers that will be released about the middle of July. We go to the next slide. Oh, perfect. Thanks. So we'll be releasing a second set of concept papers. And then from there, we'll be going into basically starting to draft the application. And we plan to share those second drafts with CMS and ask CMS being our federal partners, and ask them to start assigning a team to start to work with us and get us some feedback on the second version of those concept papers that we can then start refining and starting to get some feedback as we go into drafting the application. There'll be a whole nother second round of opportunity for folks to continue to provide input. We'll have an application out later in the summer, and we'll go into tribal consultation. There'll be an opportunity for public comment, and we also expect that there'll be some places where we'll want to stand up some technical advisory groups on some particular topics. So we're kind of transitioning from high-level concept papers and starting to get more into the details this summer. We've also been doing had several webinars with through our community partner outreach program, and as you can see here, we have 2 scheduled for this week, one in English and one in Spanish. Next slide. So we're going to start to give a summary of some of the feedback that we've received to date. There's also a report that was submitted to the board and gives you a bit more detail So what we'll go through today is a pretty high level summary, but there's a more detailed report that you can dig into. Next slide. And next slide. Just a reminder, the 4 priority areas that we've been focused on, are sort of 4 puzzle pieces that we feel like fit together to really push forward on health equity. And so I think these four pieces sort of fit together and kind of complement one another. They do kind of blend a little bit from one to the next, but first and foremost, we're not sure to say first and foremost, but first is getting folks covered and getting folks who are eligible for the Oregon Health Plan enrolled and making it easier for them to stay enrolled. This is critical to be able to access the healthcare system, is to have health insurance coverage in the first place. And so sort of step one is getting more folks covered. Second is having a more equity-centered system of health. So when folks do have insurance coverage, making sure that the system that they're getting healthcare through is really equity-centered and puts patients in the center and really helps them get the care that they need to be healthy. The third is providing more flexibility in how the health system can spend dollars to get people the services that are going to keep them healthy and really advancing our global budget to do that. And then finally, we sort of started to shift away from what we originally started calling reinvestment for savings and more talking about places where we actually need to make some targeted investments and to really make sure there's community voice in places that we need to actually add some dollars if we really want to be able to address health inequities and shift some dollars around within the system. So those are our 4 priority areas. I'll start with coverage and then and kick it over to Lori for the second one. Next slide. So what's the problem we're trying to solve? We've made really significant gains in the state since implementation of the Affordable Care Act to get more people health insurance coverage. And overall, I think have felt like we've been pretty successful. We went from about 85% of the state having health insurance to about 94% of the state, and leaving about 6% who are uninsured. And about half of those folks, about 3%, are uninsured for the entire year, and about half have coverage at least some point in the year. But what we really realized is that as we look deeper into the data is we still have a lot of work to do. First, that 6% uninsurance rate is not consistent across all populations. As you can see at the bar chart on the bottom, we have much more significant rates of uninsurance for communities of color, 12% for Hispanic Latinx, 11% for American Indian Alaska Native, about 8% for Black African American communities. And all data points we've been able to see looks like this is probably going to get worse after the pandemic. And so we have really significant inequities in terms of who has insurance. This also translates to inequities in terms of who can't access the healthcare system because of cost. And we see similar trends around folks who aren't getting care, who say they aren't getting the care that they need because they can't afford it. And so even though they may be insured or insured for part of the year, they're still struggling to access. It's not affordable insurance, and they're struggling to access. We also have seen that there's a fair amount of folks who are quote unquote churning. And what we mean by that is they're moving from one type of insurance coverage to another, namely from Medicaid to private insurance, back and forth as their income changes, as they're changing jobs, as their eligibility determinations come up and they get lost in the paperwork. And so we see a high number of folks who come onto the Oregon Health Plan and then fall off and then come back at some point in the next year or two. And all of that creates breaks in care and coverage and really hard to keep people getting things like preventive care and the services that they need and maintaining the relationship with their providers. Why don't we go to the next slide? So our vision moving forward, and this is in part Medicaid and in part broader than Medicaid, is really to be pushing towards really getting to as close to universal coverage as we can possibly get, and really ensuring that really as close as we can get, all people in Oregon have insurance coverage, and that we eliminate the inequities that exist in terms of higher rates of insurance among communities of color, and really get to the point where everybody has insurance coverage and that it's consistent and stable. Next slide,
Could I just add a quick comment, Jeremy?
please.
I think we sometimes we get caught up in coverage because that's the thing we're focused on, but obviously coverage in and of itself isn't the point. The point is access to primary care particularly. And one of the things we saw in the pandemic is that lack of connectedness to the healthcare system was a huge barrier to effective quarantine, isolation, testing, vaccination, all those kinds of things. So it's really providing that connection to the system that coverage provides.
Thanks, Pat. And I would say, I think especially when we talk about the churn and people cycling between Medicaid and private insurance back and forth, that becomes difficult to maintain that relationship. And so we've heard from providers who lose their patients and then have to, they show back up when their insurance coverage changes, and they have work to do to get them caught back up on the services, especially preventive services that they need. So a few themes that we've heard as we've been getting feedback, broadly, I would say, general support for us continuing to push towards getting to universal coverage, and specifically looking at populations who are struggling to maintain their coverage and losing continuity. We've heard from folks around children in particular that fall off because their parents struggle to get through the paperwork of going back through eligibility. And so even though likely their finances haven't changed a whole lot, the children lose coverage. And we also know that kids are more likely to get the preventive care that they need if they're insured, and especially if they're insured with the same insurance as their parents. When they have different types of coverage, it becomes more difficult. You're navigating two different insurance plans, two different provider networks, and just becomes much more difficult for kids to get the preventive care that they need. We also have been hearing a lot of stories around folks who just struggle to navigate through sort of life transitions. Something happens with moving, or something happens with a family member. Maybe the family member moves to a different social system, and each time they do that, it becomes difficult to figure out how to re-navigate the health system. Sometimes they may suddenly be dealing with two different CCOs in two different parts of the state, as an example. We also heard, and I think to Pat's point around, this isn't just about getting people insurance. They actually need to be able to access the care that they need as well. And so making sure that there are enough providers that folks can access culturally responsive care, the right types of care, and that even folks who have coverage through the Oregon Health Plan, they still struggle often to be able to figure out exactly what their benefits are or exactly who their provider is. So don't want to lose sight of the goal here isn't just to get insurance coverage rates up. It's also to make sure folks can adequately access the care that they need. We've also been pulling data and have seen now through the pandemic in a way we never really had before what this churn looks like. We have not been going through eligibility redeterminations for the last year. And what that has meant is that pretty much the only folks coming onto the Oregon Health Plan at this point are folks who have never been on the Oregon Health Plan or haven't been on for at least 2 years. And so that gives us we have a pretty good idea about the 250,000 folks who've come on through the pandemic, how many of them are off and on within the last year or two. And it's a pretty high rate. Next slide. The other issues we've been hearing is that, and this isn't a new issue, but as we've been talking to folks around, how do we make sure people actually can maintain cover, if they're eligible, they can get in and stay in. And we often hear things like changes in address are just a huge issue. So very high rates of people moving that's not having an updated address, or the CCO not having an updated address. And so folks they lose their coverage, even though they may still be eligible for, likely still eligible for it. It becomes hard to do outreach, hard to get paperwork to them. And so I think we see folks who lose coverage until suddenly they need healthcare again, and then they have to come sign back up for it. most of these I think I already covered in my last comments. So I'm going to turn it over to Lori next to talk about the equity-centered system of health.
Sorry, it just took me a minute to get off mute. So good morning, everyone. Let me see if I can set my system up. I lost the ability to see slides when I switched that. So let me see. There we go. I apologize. I had to move a window so I could get off mute, and then I lost the slides. Darn it. Well, I'll pull them up in a different way since I can't see them on the screen. I'm going to talk about, as Jeremy said, we received a lot of feedback, and I'll start in while I'm pulling up slides. We received, have been receiving feedback across the month. I'm going to be reviewing what we've heard so far on the equity-centered system of care piece. There we go. I got them now. And just talk about the feedback that we receive and kind of where we're going. You know, the problem that we're wanting to solve on this big policy area is the complications that members have in navigating our system. And we know and have heard that those complications dramatically increase when a person's in a time of transition. And so we've talked with lots of members of the community, both providers and CCOs and members and people who represent communities of color, that those about what those transitions are. And so they might include, I mean, and what we've heard in terms of feedback, you know, certainly people leaving the criminal justice system, but also members who, you know, youth who are leaving foster care and going back to their parents, youth who are transitioning from pediatric care to adult types of care, particularly those kids with complex healthcare needs, members who are also transitioning from Medicaid to Medicare. So it's the types of transitions where eligibility changes a little bit. Often a person's doctors or the place where they're living changes. And so it's important to address those particular transitions in concert with the changing social needs that people have when they're making these transitions. Next slide, please. So our overall vision is that, you know, people have equitable access to services and supports they need. And I want to highlight both what Pat brought up and Jeremy talked about. The first step is getting insurance coverage, but beyond that, it's access. And it's access to primary care, it's access to the services that, medical services that members need, and also the social supports that they need to be healthy. And we've heard from lots of community members that that access is not equitable in our state. Next slide. So some of the main themes that we've heard so far, I highlighted the first here, that there are big disparities around access to care. Also, members of the healthcare community and communities of color have stressed again and again the need for coordination of care, especially during these times of transition that I highlighted, but also coordinated care that is culturally specific and language appropriate. We've heard from members and those folks who work with our members closely that there are particular covered services that aren't meeting needs, or additional services that we think would be important to start to cover. And then finally, that we've heard lots of feedback on developing a robust workforce. We heard that from Courtney earlier on the public comment, and I want to highlight some of this workforce is what we would consider slightly, one step away from the medical system. So what I'm talking about are peer support specialists, people who can meet the needs of members without having to fully engage in the healthcare system. An example of a peer support specialist role could be, if a member is leaving the criminal justice system, they got clean and sober, they still may need a peer support person to be checking on them to help them maintain their sobriety. Right now, we have lots of difficulties around how to pay for those kinds of services and how to get those services covered by Medicaid. I will say that, with the feedback that we've gotten really has highlighted the kind of encouraged direction or encouragement about the direction that we've been taking on this to focus on health equity and making investments in changes to the health system that will eliminate health disparities in the future. Next slide. Some of the big transitions or people who are suffering from limited access to care are people with disabilities. We've heard, there's can be issues around accessing a provider and services for folks who are disabled, folks who come from a community of color, homeless individuals or people who are at risk of becoming homeless, and then our undocumented population having a fuller access to services. Next slide. Here are some of the comments that we've received during our public sessions. I do want to emphasize that Jeremy mentioned we provided a report that's very detailed that includes lots more information. So I encourage you to take a look at it. But some of the specific barriers are around coverage. For example, that many of the evidence-based benefits don't necessarily serve BIPOC populations well. Rural members have difficulty accessing services, often can have difficulty with transportation. Again, I mentioned people who are leaving the criminal justice system, but when they walk out the door, it can be very hard to make sure that their behavioral health needs are met. And then issues for folks with disabilities or special needs, making sure that they get access to care and access to the doctors that they need. Next slide. I'll dive a little bit more into some of the specific topics that we've heard about. Next slide. So here's some of what we've heard around coordination, care coordination, and care coordination with an equity-centered focus. So that means eliminating barriers to care and building on existing community resources. And so there's been a recommendation to think about the barriers that folks face in accessing care and how health is defined beyond just the medical system. This is an area that we're thinking lots about, as Jeremy mentioned at the beginning of our presentation, when we're thinking about additional federal dollars, what can we do to promote health across all of our communities? And that also there is concern in providing upfront dollars to communities, and then not having that sustainable really can breed mistrust in the system. So thinking about how we make investments that will have long-term return on those investments. Next slide. Just a review of some of the covered services that have been brought up. One is telehealth, continuing that, and we certainly plan to do so. We've learned lots about telehealth during the public health emergency. Another one was treating interpreters as providers, so for billing purposes, so that interpreters can have adequate reimbursement. Again, more on workforce around reimbursing mental health counselors. We've had requests around reimbursement for traditional health workers, community health workers, peer support specialists, and the like. We will be focusing, on that in this part of our waiver. And then there was other types of coverage. We heard a lot about vision. We don't need a waiver to cover vision services. That's really something that has to do with funding and other aspects. But another innovative idea that was brought up is access to parks and recreation. That many people live in apartments, or they live in an urban area where they don't have places to exercise or to access the outdoors. Next slide. We've heard lots about housing, lots about social needs that aren't met, and behavioral health access. I think when we're talking about social needs, the two big areas are thinking about housing and then also behavioral health system access, which to some degree is affected by the shortage in workforce, but also the lack of culturally appropriate and linguistically appropriate behavioral health services as well. In terms of housing, we have heard there isn't adequate housing available. It's not something that Medicaid's going to be able to solve, but really thinking about how we coordinate with housing services and provide different types of options. So for example, short-term vouchers to allow people to get into housing in the first place is an example. Next slide. I've already talked a little bit about workforce, but we'll jump to the next slide. One is, there are concerns about how much it costs to do coordination, particularly in the way that our system's designed. So how can we, rethink the system, provide different types of providers, Medicaid reimbursement, and other innovative ideas around how to better provide care coordination, particularly for, we've talked about those folks in transition. And then again, really thinking about ensuring culturally appropriate care is provided during care coordination as well. Next slide. I'm going to turn the next section over to Jeremy, and then you'll hear from me on the federal investments at the end.
Thanks, Lori. So the third area is around more flexibility around how CCOs can spend dollars, and largely what we're talking about, although not entirely, is really trying to advance the global budget concept. Some of the problems that we've struggled with, we've talked about this before. We've come a long ways over the last 10 years in terms of moving towards a global budget. We've blended a bunch of various funding streams together into one capitation arrangement with CCOs. Previously, behavioral and physical and oral health services were all paid for entirely separately. So we've been able to bring those together. We've gotten a lot of flexibility from CMS for CCOs to be able to spend on what we call health-related services, which are things that are not sort of traditional medical services, but are things that can help with health and help keep people healthy. But where we've really struggled is the primary way that we have to pay CCOs is still based off of what they spent on healthcare services in the last year. So they can spend on health-related services, but they don't sort of get as much credit for it, if you will. And there's still financial incentives in the system often to provide a more expensive healthcare service when something that could have prevented a need for healthcare service would have been cheaper and easier and better for the patient. And so what we've seen is that even though all CCOs offer health-related services, we haven't seen as much spend on it as we expected. And we hear that it's difficult to figure out how folks can access those health-related services. And health-related service is a very, very broad category of things that are not healthcare. Could be food, could be, housing supports, could be, could be support with heating or cooling or things of that nature. And generally there's an application process and somebody has to apply, and it's very difficult to know, whether that's going to be approved or not. It's cumbersome, and it's easier often to just, okay, we'll provide the healthcare thing. We know how to do that. We know how to bill for it. We know how to get reimbursed for it. So we haven't seen as much spending on things that keep people healthy and out of the healthcare system in the first place. We know that we know that only about 10 to 15% of what impacts health is actually healthcare. The other 85-90% is social services. It's things like housing and food and issues that keep people healthy and allow them to be well. We also know that we have not seen as much shifting around of where healthcare dollars are being spent as we expected with global budgets. One of the main points of having global budgets in a CCO was to really create community conversations around how do we shift around and best utilize limited Medicaid financial resources in a community to spend those the most wisely to keep people healthy. And we know that when the system sort of fails folks, people end up in jail or the emergency room oftentimes. And oftentimes that's because they aren't getting things that they needed to stay healthy. A lot of things like behavioral health services, timely access to behavioral health that would be able to avoid a crisis or more acute situation. And so the whole point of CCO model was to create a local community accountability around a global budget. And that part of that would be shifting resources from one part of the healthcare system to others to try to meet needs. And that might be spending, increasing spend locally on behavioral health and moving it away from just as much spend on physical health system. We haven't really, frankly, seen a lot of shifts in that area. I mean, we largely see spending kind of in the same places within the system that we did before. And the result is we've got access to behavioral health as an issue, and access to oral health in other places. And we're not going to be able to achieve health inequity or eliminate our health inequities without addressing some of those shifts that need to happen. We've also heard pretty consistently that communities want more say in how CCOs are spending their dollars. And this gets back to comment Pat made very early in today's meeting around the board's health equity definition, and that part of that definition is shifting power and redistributing resources, and communities. In order to be able to do that, communities need to have a voice, especially communities that are actually impacted by where the spending is happening. And so we've increased that voice over the last 10 years, but we still see and hear very consistently from members and advocates that they need to have a stronger voice if the goal is to be making sure that the global budget's really serving members and pushing forward on our goals around equity. Next slide. So where we really want to go with the next phase of global budgets is really a new model of how we build a budget for CCOs that both provides predictability, but is much more flexible and creates more of a financial incentive for CCOs to invest upstream in places in prevention and community health, in places where we'll see a return on investment and lower costs and better outcomes for patients down the road. Next slide. Our goals at the end of the day is to get people the care and the supports they need to stay healthy, whether that's a healthcare service or that's something else. We really want to make sure that CCOs are also, can we go back one slide? Or maybe I need to go forward too. Somehow my slides are, okay. I think a slide just got dropped. That's okay. We want to make sure that CCOs are increasing their focus and their spend on health equity as well, and spending global budgets in a way that are specifically addressing equity, and that includes focusing more on prevention, focusing more on care coordination, on quality, increasing the amount of say that communities have and how global budgets are spent. And that if we are able to do that correctly, we think that will create some savings, and that will help us ultimately meet our goals around meeting the cost growth target. So some of the main themes that we've heard, we've certainly heard that the folks do want more flexibility. We've heard this both from, I think, from CCOs as well as from advocates, that folks want to be able to see more spending on things that aren't just traditional medical services, and they want to be able to see more flexibility, and that if we really want to achieve our vision around what a global budget could be, we really need to increase that flexibility and eliminate the cycle that we're in, where CCOs are primarily paid just based on last year's healthcare spend. We've also heard pretty consistently over the last couple months that there needs to be accountability that's tied to that global budget. This can't be just about flexibility. It needs to be coupled with stronger accountability for what members need, from what community is saying, and there needs to be a mechanism for program integrity built in to ensure that quality and access is maintained. And then third, we've heard around standardization. So today we're talking primarily about Medicaid, but there's all sorts of other payment reform efforts happening across other parts of state healthcare system through PEB and OEB. We're talking about global budgets and other places as well. And so trying to create some alignment and create the space where we can be moving more towards global budgets and Medicaid, but doing it in a way that's really aligned with other efforts that are happening outside. We've also heard around standardization around data and incentives as being important, and that wherever we can, that we're building off of we're trying to create more consistency in terms of data collection and incentives, but also create the space where we can keep pushing forward, and that we can keep innovating, and that we have a place to create new quality metrics, new outcome metrics that are really going to help us with equity. Next slide. I will say, I think there's some historical reservations to this. I think folks who've been around for the last 10 years have seen how difficult it's been for us to try to crack this nut with CMS. That the challenge is that CMS has certain regulations that say you need to build capitation rates for managed care entities in a certain way, and that we've often had sort of a battle of sort of policy goals and regulations that say you need to be able to sort of count things a certain way, and you need to build rates a certain way. And so I think folks are a little reluctant to believe we'll get as far as we would like. I think we really feel like this is our opportunity to kind of swing for the fences, and we'll see how far we can get with CMS, and they may or may not want to go as far as we would like to go. But I think there's some reluctance. The folks will say, yeah, we've kind of been down this road before, and we've seen the struggles that we run into. So I think there's a little bit of hesitancy there. I think there's also a bit of tension of, at the same time that we're trying to get a really flexible global budget that the community really controls, that we also hear from community of places where folks feel like provider rates need to actually be increased, and they'd like us to direct that or make that happen in certain ways. Or they would like us to really push for CCOs to make investments in certain populations or in certain places, and that just creates some tension of how directive are we in terms of how CCOs have to spend within their global budget. And I think there's a bit of tension that we've received in some of the public input, where folks want us to try to solve some of those problems more directly by requiring provider rates to be increased, as an example.
I could just make a quick further comment on the global budget issue. Will Rogers said it's not what people don't know that's the problem, it's what they do know that just ain't true. And if we take another run at global budgets and actuarial soundness and lose again, I think we have to actually stop saying we have global budgets. We've been saying it all along, and it's not been true. And if we aren't able to make progress on it, then we need to find a different way to talk about how we do the budgeting in the system, rather than sort of pretend it's a system that it really isn't.
Thanks, Pat. With that, I'm going to turn it back over to Lori.
Great, thanks, Jeremy. I'm going to finish us out, I think, and we're going to have some time for discussion. Thanks for sticking with us on this rather long presentation. What I'm going to talk about now is the fourth area on targeted investments. It's going to be a little shorter, and then we're going to jump into some kind of strategic direction that we'd like some feedback on, and certainly would like feedback on. I'll pause when I finish here and just get feedback on, you know, what we've heard so far and any thoughts that you have. So we've been thinking about, you know, requesting from the federal government additional dollars. We don't know whether we will get them, but part of our pitch for that is that by maintaining a sustainable rate of growth with the global budget, that we would be saving the federal government lots of money, and that we'd like to share in some of those savings. The mechanisms of how that would come to us, you know, we're working on, and we think that the Biden administration has some doors open that could allow this funding to come. So some of the thinking is, and the questions that we've had for community is, well, if we do get some additional dollars, how would those, you know, what would you like to see those dollars invested in? And, you know, what we've heard and what we thought both are that, you know, these investments really need to focus on the underlying aspects of health inequity at the community level. And so, you know, in this slide, you'll see, you know, thinking about housing and people who have food insecurity and children and families, and, you know, thinking about the underlying causes of inequity as opposed to just focusing on the health system alone. Next slide. So some of the main things that we've heard when we're considering investments in or equity investments in communities, you know, we've heard lots of, I guess I would say, varying opinions about this. There's lots of questions about the role of the CCO and this overall investment for community. You know, who decides where those investments go? Is it the CCO and you know, our delivery system model? Could it be community advisory councils, other community voices? And we're going to have some time to discuss this a little bit more later. There is big support for a longer term investment, but also concerns about sustainability beyond that. So the federal government would not be providing dollars past the, you know, they don't commit past 5 years of the waiver. Oftentimes, when they provide funding, they'll do it up front with the idea that the state will start, you know, backfilling some of that. And so how do we make sure that whatever investments we make, you know, have a kind of a sustainable back end? And then, also, there are some concerns if we create the equity zones that we had proposed, you know, are we creating new silos in our system, and how do we look at equity and engage in community in a way that they have power and voice without creating silos? Next slide. So here's a couple quotes that get at what I just talked about. There's some concerns. We've heard this particularly from the delivery system about creating equity zones and creating a more fragmented system. However, you know, on the other side, I would say we heard pretty strongly from community, yes, this idea of equity zones is important because it's a shift in power in terms of deciding, you know, who makes the decision about what the community needs. The other piece that we've heard about, and I brought this up before, is, you know, this long-term continuity of investments, that it can really breed mistrust with the community if you come in and make some investments and then they're short-term and kind of left with no sustainability plan on the back end. Next slide. So what next? We're continuing to gather feedback. Before I jump into this, what next? We're going to talk a little bit more about the health equity zones at the end on the discussion. So I don't want you to feel like I just dropped that topic. But that's the feedback, and I'd say in some ways kind of that tension that we feel in terms of investment, and that's really who controls it, and how do we make sure that investments in social needs and investments in community are aligned with the delivery system and the way that we provide healthcare. So we want those two to dovetail, but it's really changing structure and power to a certain degree that of course big change is hard and causes lots of questions. So hoping to discuss that a little bit more at the end. So where are we going with this? And that means the whole waiver. We're continuing to gather feedback this week. We meet with the Health Advisory or Health Equity Committee of the Oregon Health Policy Board later this week. We have 2 of our community partner meetings today and tomorrow. And we're continuing to get lots of written feedback from both members of the community and partners. The OH team is actively reviewing and incorporating the feedback that we've received so far and that we plan to get over the next couple of weeks to help refine and improve the direction of our final concept papers. We've been meeting with tribes all along this, over the last months of this process. And we have formal tribal consultation that begins in August. The other piece that we've been contemplating is, as Jeremy mentioned, the concept papers will move from kind of high-level concepts to having more detail. When we meet with Center for Medicare and Medicaid Services, they're going to want to see detail about what they're agreeing to. And so we are thinking about for at least, it may be all 4 topics, it may be fewer, technical advisory groups that have, people on the ground who do the work, who where the work affects them, to advise us on the details. There will be another formal comment period in September, and then we certainly invite ongoing input throughout, the entire process. Next slide. So I'm going to turn this over to Dr. Bangsberg to just lead any discussion thus far, and then we'll dive into 2 different topic areas where we'd like feedback. One is on the incentive metrics program that we are proposing, and the second one is around this idea of health equity zones.
Thank you, Lori and Jeremy. I'd like to open it up for a discussion. All right. Bill, please. Bill, and then John.
Very much, David, and thanks, Lori and Jeremy, for a great presentation. Really appreciate the summary of the process as well as the content of the proposed waiver application. Just want to really applaud the bold vision, pushing the boundaries of what CMS might accept. Very much like the approach of investing in community resources with the goal of reducing healthcare costs that should result in net savings to federal and state government. The challenge, of course, is going to be to convince CMS that the savings will actually occur, but that means the challenge for us is to make sure that those upstream investments are very well targeted. On a couple specific issues on equity, there's a clear focus on the root causes of inequity, the upstream factors. And I appreciate this is a big, complex problem and that we don't want to try to boil the ocean and try to fix every problem all at once. But I do encourage us to consider putting at least some additional focus on inequities within the healthcare system, like perinatal services. There may be other ways to get at that rather than through a waiver, but at least an acknowledgement of those activities are underway, I think would be important as part of this application. Just a couple other comments on global budgets. I think moving toward greater flexibility and the strengthening of accountability are both very important steps. I will at the same time agree with Pat's comments about our need to be clear and accurate about whether we're really using true global budgets. And then finally, the point, Jeremy, that you made about the importance of standardization or alignment among state payers and purchasers, so that we're that the CCOs and other organizations can be operating with the kind of same kind of single approach on both payment models and performance measures, I think is really important. So again, applaud the great work that's been done so far. Look forward to further refinement over the next several months. Great work.
Thank you, Bill. John, did you want to?
Yeah. Overall, I just think this is terrific work, and so many elements I think are provocative, and they should be. As I listened, just two things to mention. I think you have one group that's coming in and through retroactive eligibility. And is that group a group that, now that you have more data on who's going in and out, are they a high risk group? And would CMS be willing to do more for them when they fall out of eligibility? I mean, I've always thought retroactive eligibility is wonderful, but it means really the system is taking the insurance risk and really not getting resources to prevent that from happening. So, that population that comes in through retroactive eligibility, I think is interesting. The other thing as I listened is, is there an opportunity to do something with 60 to 64-year-olds who are headed for a huge transition from, nothing to Medicare or Medicaid to Medicare? We know they're a really high risk group. And again, I think as you think about approaching CMS in terms of, would you work with us to really fill the gaps, especially for this high risk group? And if we succeed at it, will you share the savings as they go into Medicare? Because I think you could argue you could make the most risky 60, 64-year-olds much better prepared for Medicare, and potentially, not falling into dual eligibility. So just might think about those two things.
Yeah, those are really interesting comments, John. I don't know if I have any immediate response. I think it's a lot in there for us to think about. I don't know that we've done and Lori, maybe, I don't think I'm not aware of us doing an analysis of sort of the risk of folks who are in retroactive eligibility. We know at least one provider system has told us they did some analysis of churn, of that they are actually able to identify the cost of folks losing coverage and then the cost of getting them back in and caught up on preventive services, and could actually articulate that cost. And we're seeing if we can get our hands on it, but I don't know that we've looked at the retroactive eligibility population ourselves specifically.
I just want to comment on, John, your 60 to 64-year-old is really interesting. We did hear, I don't know, on one of the webinars with community that we did, I think it was Waiver Days, there were lots of comments around that transition from Medicaid to Medicare. And one of the things that happens is people who are on behavioral health, receiving behavioral health services, a lot of that drops off at Medicare along with dental. Right. And so how do you get that, what do we do about that? And that people also lose their whole provider network changes. And it was a big concern, whether or not they become a dual or if they just go into standard Medicare. So that's a very intriguing idea.
Yeah. And the other thing I would just mention is, I know it's small, but there's this small population that isn't eligible for Medicare. And to what degree are those folks impoverished? To what degree are they really high risk folks. You know, they must be folks who have been hardly employed or, you know, something of that sort. So maybe there's a number of them are wealthy. I don't know, but that little group, especially as we get to this cover all people concept, you know, and by the way, boy, I hope you go to CMS and say, look what we're doing in terms of cover all people. Come on, match this. Come on, you know, look what Oregon's doing here. So great work.
Yeah, thank you.
Other comments?
I just had a quick comment. As with the sort of coordination piece between providers, patients, and specialists, I just see that there's a lot of challenges there, and it might be part of what's driving the access issue for at-risk population, people in the BIPOC community, because it's when you pick up the phone to call your doctor and you need something, you get run through the ringer. I mean, it's 5 phone calls just to figure out who you actually need to speak to in order to get started to figure out what you need to do in order to get the care you need. And I would imagine some people just give up on it. Because it is really, we're working through a pretty complex system, and it's obvious to the consumer, right? It's obvious to the person who's trying to get that care. So as we go through this process of, you know, optimizing those areas, and as we look at where to spend dollars on coordination, I would really like to see us do what we can to minimize that visibility to the customer, and, you know, create, you know, a no wrong door, or, you know, no more than 1-2 phone calls to actually get where you've got to go as a patient and get that care, because it's really impacting access.
Thanks, Jessica. And we definitely hear that and see that in the comments we get from members. You know, and I think you know, broadly, if we're in a place where we're moving towards everybody has insurance coverage of some sort, then how do we make the system simpler and easier? How do we make it easier for folks to be able to navigate? And I think that is a kind of a common theme that maybe we didn't call it explicitly at the front end, but I think is showing up of how do we make the system overall easier for folks to navigate and to get the care that they need.
Yeah, thank you for mentioning that. I mean, I see it on the private sector too. I have a family member that does receive OHP, and I kind of help them to navigate that. And it's much more of an issue on the Medicaid side than what you see on the private side. Believe me, there's issues on the private side of the aisle too, but I notice it's particularly cumbersome for, you know, when I'm trying to figure out how to navigate this system from the Medicaid side of the equation. So thank you.
Thank you, Jessica. Also wanted to point the board's and the waiver team's attention to some comments that Ebony Clark provided regarding the specific concepts. I think overall she has broad support for this concept and the individual concepts. She has specific comments around behavioral health, housing, and the justice system. Regarding behavioral health, she wanted to see more alignment with community mental health, CCOs, and private payers, and also was concerned that we should move from a one-time investment to a sustained investment. Regarding housing, Ebony warns us that there's a pending foreclosure and eviction crisis that we are facing, and urge OHA to add strong language to uplift housing as a critical social determinant of health. And regarding the justice system, she has broad support for this, but propose that Medicaid paid for and expand pathways for services for individuals with dual diagnosis and complex behavioral health issues in the criminal justice system. I think all really important points. I just wanted to comment on, you know, I was surprised that one of the concerns was fragmentation of the social determinants of health. I really see that as integration, in that you know, behavioral health integration is all about integration. We are creating more integration with flexible spending, with housing, with the criminal justice system. And I see it as, really intentional integration rather than fragmentation. The problem is that these systems have been managed by different funding streams, and now we're trying to think about this as one problem, an interrelated problem, rather than several different problems. So I want to compliment you on the integration that you've achieved and trying to achieve. Kirsten?
I just want to follow up on that because I too appreciated the kind of the comment around health equity zones and the concern raised around siloing, and I was like, oh, I hadn't thought of that. So I just think I too see this as like integration and a kind of universal approach. But I do appreciate the like kind of going into that with the eyes open of being cautious about what we're creating as we do these new things, so that we don't have silos, and our vision of integration of this comes true. I also wanted to underscore appreciation for strong community voice at each stage of this, and that transfer, the literal transfer of power in listening to those voices, or even like turning over to those voices, as well as the focus on transitions. I look forward to seeing the positive impact that focus will play. I did my one kind of addition, Jeremy, when you talked about the kind of vast 85 to 90% of health that is impacted by these other things, and how we start to address housing and more in our waiver. I just, income is the largest predictor of health. And I think that needs to be reflected in our activities here as well. And I think that can come into play in multiple ways. But I definitely think that as we think about how to address the workforce crisis, which is real on many different levels, like how are we at the same time saying we want to address this workforce crisis so that patients can get the care that they need when they need it, where they need it, in the language that they need it in, but also like how are we building up that workforce and not creating additional poverty jobs, which then replicates our need for a robust Medicaid system. So, but I'm really excited about this work and really excited about the vision that helped create it. So thank you for the leadership of staff and all the voices that went into it.
Let me check in with Lori and Jeremy in terms of the rest of their presentation. We have a stop at 11:30 because we have a full slate of public comment at the end of the meeting. I want to make sure we reserve time for that.
Sure, and I'm happy to just go through a couple slides on metrics, and we'll take the last 10 minutes to get some feedback. How about that? Can we pull up the next slide? Thanks, Michelle. So one of the pieces that we haven't talked about too much yet is an idea to refocus our CCO metrics. And so I'm just going to talk a little bit about that and get some feedback. So what we're thinking is creating, I guess what I would say, two sets, and it's not really that much. I think language is different, maybe not that much different than the original vision of the 2012 waiver, where we had 33 statewide metrics that would ensure that by holding our costs down, we would not degrade quality and access for members. And then having a separate set of, at the start, was 17 metrics where we paid bonuses to the CCOs on it for improving. But we're rethinking or reimagining what this could look like, and instead of having 33 statewide, what were called statewide metrics, and then a set of incentive metrics, thinking about upstream and downstream metrics. And the upstream metrics would focus on health inequities or the root causes of those. So these metrics would focus on things like socioeconomic factors. And one example is the new CCO incentive metric, meaningful language access to culturally responsive care. So that upstream set would be a smaller set because they'd be hard to achieve and they'd really be focused on health equity. And then a downstream set of metrics that would, I think, represent the 33 statewide metrics that we have that would focus on our medical system and focus on things like screenings, treating chronic disease, and immunization. Now, for those, if we continue to push on obtaining good REAL-D data, we can, stratify these by race, ethnicity, but the focus would be on the medical system. Next slide. And part of our thinking on this is CMS has established some core set of metrics. Through 2022, so through next year, we can, reporting on those are voluntary, but starting in 2023, CMS is going to require us to report on these at the CCO level anyway. So the thinking is, why not capture those and use those as our downstream metrics, and so that we are trying to align our metrics with the CMS requirements. That state quality bubble on the right lower side is our 33 metrics, and it overlaps to some degree, but this would be really looking at the CMS core sets and having CCOs report those. And there's both adult and child metrics. Next slide. So right now, the way our incentive metric program works is there's a metric set that we pay the quality pool payments on when a CCO either meets the benchmark or an improvement target. And those metrics are selected through the Health Plan Quality Metrics Committee. Well, they pick the menu, the overall menu for the state, and then Metrics and Scoring Committee picks within that menu and also selects the benchmarks. So our new proposal would be that we'd have upstream and downstream metrics, and the downstream set would be the CMS core set that we don't have a choice on. And then the upstream metrics would be focused on equity, and we have a greater role for communities and members in setting the priorities for those metrics.
Laura, can I just add, so I mean, really the fundamental shift here, I think, is right now we're picking some set of quality metrics. It's ranged from 12 to 17, and they're mostly medical. And we've been trying to push more into sort of new innovative non-medical metrics. What this would do would change the selection process to be not so much focused on the medical metrics anymore. There would be sort of some alignment, and those would be fairly set, and really would be focusing the quality pool dollars and the whole process to be much more focused on these upstream, new innovative, equity focused metrics.
Right, thanks, Jeremy. So the focus is equity, since that's the focus of the waiver, and a smaller set because these would be more difficult to achieve, and likely involve a broader spectrum of our community as opposed to just the doctor, primary care office, for example. Next slide. Yeah, so I am going to pause there in our last 5 minutes and see if there are comments on the metrics. And then if there is time, we can talk about health equity zones. And if there's not time, I propose we bring this topic up at our next meeting, because I know we're going to get lots more feedback on it.
Any questions?
I'm guessing John will have comments.
I think I would just say I really support this conversation. I really support looking at what we're doing in terms of performance measurement, and I think the way you're doing it is just fine. So I support the conversation, and let's see where it goes.
Great.
Oscar, I want to make sure to check in with you to see.
Yeah, no, I'm really excited to hear about this sort of prioritization that could be coming more from our community level. So it's really, really exciting, and I think it's headed in the right direction.
We do have a lot of public comments today. I want to make sure we have time for that. I will check with the board. Is okay if we, I think the health equity zones requires, certainly more than 5 minutes. We need to, I think spend some time on that. So if there's any, without any objections, I'd like to have a discussion on health equity zones, maybe our next meeting. Jeremy, Lori, is that okay with you? All right.
Yes, I agree. It's going to take more discussion, and I think we will receive more feedback between now and then that we can provide. So we'll plan on spending a good amount of time on it next time. Thanks.
Okay. Thank you all. Appreciate the discussion. We'll move
Thank you.
To our second session of public comment. We've received 12 requests for public comment. And these are comments related to the issue of wireless technology and radiation concerns that are tied to the Public Health Division report released in 2020. We're aware that similar concerns have been made to staff of the Public Health Division, OHA, and OHA Communications Division. We're here to hear these public comments, and additional concerns can be directed to OHA Communications. So we will share these concerns, both written and oral, with them. Once again, as we mentioned last time, we deeply appreciate your public testimony. It's one of the most powerful ways we can demonstrate the importance of listening and learning from the public. Because we have so many people who want to provide comment, we're going to listen. We're not going to respond in real time during our meeting today, but we will bring these comments back to staff, discuss them with staff, and decide on our appropriate response. Each presenter is allowed 2 minutes. And often doesn't feel like enough time, but to make sure that everybody has a chance to share, I'll ask you to stay within the 2-minute timer. And again, we will review in our working meeting all the oral comments as well as the written testimony. So with that in mind, when you provide your comment, please state your name and affiliation for the record, and we'll start off with Shane Riley.
Hello, can you hear me?
Yes. Mm-hmm.
Thank you. I'm a building biologist certified through the Building Biology Institute to assess and remediate electromagnetic fields, including wireless radiation. I was stunned that the OHA's report for State Bill 283 neglected to take any measurement of RF power densities from any school. As a professional in the field of electromagnetic radiation, my entire work stands on detailed measurements to understand any actual threats to a healthy indoor environment. The type of radiation classified by the WHO's International Agency for Research on Cancer as a class 2B carcinogen has changed a lot since 2011. The technologies that emit this type of radiation have not become any safer, but instead have become exponentially stronger. Also, reviewing a study on the danger of a single cell phone really does not apply to a classroom with 25 cell phones, 25 tablets, all connected to an industrial strength Wi-Fi router, and many times all underneath a roof with a cell phone tower on top of it. And the majority of schools in the district where my daughters attend school do have cell towers on the property. I find this to be an extremely dangerous practice, but I'm not going to address it further here. In case you're not aware, kids are at a high risk from wireless radiation for several reasons. One, their developing brains are uniquely susceptible because of how active the cells are. Two, kids' physical structure and bone density are less protective against radiation. And three, the earlier in life you're exposed to radiation, the longer your DNA has to cause cancer. The quality of the OHA's review is lacking. And even though it may be painful to acknowledge that school environments are unhealthy for kids, it is infinitely more painful and expensive for our society to bear the burden of latent cancers quietly seated in our kids by falsely concluding that there is no risk from these powerful types of radiation. Thank you.
Thank you very much. Just a note, we've received We'll review those as well. I'd like to turn to Catherine.
Hello, thank you so much for this opportunity to speak. Again, my name is Catherine Katzen, and I'm an elementary school teacher. I'm here today because the American Public Health Association's Public Health Code of Ethics states on page 5 that public health practitioners and organizations have an ethical responsibility to prevent, minimize, and mitigate health harms, and to promote and protect public safety, health, and well-being. Yet the OHA report does not address prevention. Instead, this report will serve to promote false safety assurances and promote the unrestrained use of wireless in schools in the state and nationwide. The OHA report's conclusion is absent of any precautionary recommendations to protect children, despite the fact that numerous published reviews on RFR conclude that the public should reduce exposure while research continues. The OHA report has a glaring absence of adherence to public statements put forward by the American Public Health Association. The precautionary principle has been put forward as the cornerstone of public health for decades. Dr. Ronald Melnick, who led the design of the $30 million U.S. National Toxicology Program study during his 28 years at NIH as NIH toxicologist, presented the study findings in 2019, concluding that health and regulatory agencies need to promote precautionary measures, especially for children and pregnant women. In children, the risk can be greater due to the increased penetration, as well as the unique sensitivity of the developing brain. In line with the APHA Code of Ethics, OHA should retract their report, redesign the study to follow best practices for systematic review, and ensure that the summary language includes language that will not be misinterpreted to mean that RFR has been found safe, as this would be inaccurate. The APHA Public Health Code of Ethics is the roadmap forward. Thank you.
Thank you very much. We've also received your written comment. Turn next to Deborah Davis.
Thank you. For more than 45 years, I have worked at the top levels of science and policy making, including a decade with the National Academies of Sciences that produced the first studies concluding that smoking should not be permitted indoors. As the author of more than 220 scientific publications and currently as president of Environmental Health Trust, along with the former director of the National Institute of Environmental Health Sciences, Linda Birnbaum, and others, I conclude that the Oregon State report on wireless exposure should be retracted. Under normal circumstances, if such a draft had been submitted to any of the expert groups with which I worked, it would have been sent back. Our website includes copious documentation of the report's deficiencies submitted as well to you. As Oregon's health authority has done with its excellent work on tobacco, a proper review considers a broad range of evidence. In contrast, this defective report ignores thousands of relevant experimental studies, including that of the U.S. National Toxicology Program that was just mentioned. These studies show clear evidence that current levels of wireless radiation can cause cancer, damage DNA, impair thyroid function, and alter normal operation of the heart, reproductive and nervous systems. I understand that this legislature faces daunting responsibilities and has to rely on expert advice in carrying out its obligations, but I'm growing numbers of independent scientists who've documented that there have been successful efforts to manufacture and exaggerate doubts about wireless radiation, just as happened with asbestos, tobacco, lead, and most recently Roundup. Indeed, Harvard Safra Center for Ethics dubbed the FCC a captured agency for precisely this problem. My colleagues and I urge you to reject this report and recognize independent expert reviews from French, Israeli, Belgium, and Swiss authorities, and those developed by the Oceania Radio Frequency Scientific Advisory Association. Not a single one of these reports is included in the current review. By failing to consider key scientific evidence and carry out any real-world measurements and consistent with the precautionary principle, this review betrays public health. The duty of public health is to prevent harm and not to prove that damage has taken place. Thank you very much. I look forward to talking with you later about any questions you may have about our written comments.
Great, thank you very much. I'd like to turn to Courtney Giraldi.
Hello, can you hear me?
Yes, go ahead, please.
Okay, thank you. I'm asking you to please retract this report and protect our children. I'm a mom, and a cell tower went up at the top of 8 residential streets last year without any notification or warning. But what was worse than being blindsided by wireless radiation that we don't consent to in our neighborhood was that my 10-year-old daughter came down the stairs one day feeling headachy, dizzy, and buzzy. And when I called Verizon, they confirmed that that was the day they fired up the cell tower. I immediately called my city councilor and my health department for assistance, but they didn't know how to help because there is a complete lack of adequate limits set. Our health department is literally entrusted and responsible for protecting the health of the residents, but they do not have the resources and tools to do so. We had our doctors, engineers, epidemiologists, physicists, pediatricians. They all spoke to our health department about the biological harm of cell towers near residential areas causing our symptoms in our children, which prompted a dialogue with the Massachusetts Department of Public Health for assistance. But our own State Department of Public Health couldn't help. We need protections in place, and we need policies, and we need to not ignore the science, because my children and the children living in this neighborhood are living proof of wireless harm. My children and the neighbors' children are all being impacted. We know of at least 14 people who have experienced headaches, dizziness, nausea, insomnia, tinnitus, palpitations, AFib, skin rashes, and 3 additional have cancer. My own children in their own home are so sick that they have missed school. Their bedrooms upstairs on the side of the house facing the tower, when they were staying in them, they were so dizzy that they would literally walk into walls. They could no longer sleep in their own bedrooms. And so then we moved them farther away from the tower. And when the radio frequency radiation was increased, we had to move out, and they now sleep on mattresses on the floor elsewhere at night to alleviate their symptoms from the constant 24/7 exposure of this class 2B carcinogen and environmental toxin. The Massachusetts Department of Public Health on their website says if you're concerned about RFE emissions, you can turn off devices, you can move away from a source, or you can use them less. But when children are in a school and they're exposed to devices and wireless radiation from all sources, they do not have the opportunity to do so, and they do not consent. Please, we are asking you to not force our children to be exposed to something that we know is harming them, and we are the evidence of that harm. Please
Thank you for
help us. Thank you.
All right. We were having some malfunction with our timer, so I'm keeping time with my watch, but thank you, y'all. Everyone's doing a great job staying on time. I appreciate that. We will go to Theodora Scarato.
French law dictates that when you buy a phone, you're informed, keep the radio equipment away from the belly of pregnant women and away from the lower abdomen of adolescents. Yet, as we document in our report to the Oregon Health Authority, phones, tablets, and laptops are on the laps of children in Oregon schools and in their pockets, the phones. Research shows the developing brain is more affected by microwave wireless radiation, which is more absorbed into their brains and bodies compared to adults. Yet, research on children's unique vulnerability was omitted by the OHA. The resources posted on the OHA website are outdated, unfactual, and include industry consultant drafted information. Contrary to the OHA report, no health or environmental agency has ever issued an opinion on the full body of science. The EPA was defunded amidst heavy industry lobbying in 1996, as confirmed in the 2020 letter provided to you. The FDA has not reviewed the research on brain damage or reproductive damage and presents industry-tied criticisms of the National Toxicology Program on its well-scrubbed website. We provided clear documentation that the NCI has not reviewed the safety of wireless radiation despite their long webpage. EHT's FOIA investigation into the CDC revealed that numerous CDC web pages, such as the one the OHA references, was created under the tutelage of an industry-funded consultant, thus effectively downplaying health issues. The OHA links to the World Health Organization webpage, yet omits that the one-person show at the WHO EMF project who drafted this content has been well criticized for conflicts of interest, and that entity has actually not done any scientific review of the evidence since 1993, as documented on the website. And just as we are spending billions to remove lead from drinking water lines, We need to be swapping out Wi-Fi in school with wired Ethernet connections. This is a children's health issue. It's an environmental justice issue, and its time has come. Thank you.
Thank you very much. David Morrison. David, you're on mute. Just unmute your.
Okay, thanks. The mission statement of OHA states improving the lifelong health of Oregonians. However, that sentiment was not evident in the scientific misconduct practiced by OHA in the fraudulent scientific review of radiation exposure in schools required by Senate Bill 283. Crimes were committed in withholding the first draft from a Freedom of Information request. The final sanitized draft concluded radiation emitting technology in schools appears safe. The first draft came to the opposite conclusion. The credibility of OHA has been severely damaged. Those responsible, Ali Hameed, Andre Orso, Dean Seidliger, and David Howe should be fired for their part in this politically motivated whitewash. Contrary to previous OHA protocol, no animal studies were used. Although despite that, over half the studies used by OHA confirmed the harmful effects of wireless technology. One human study not used by OHA was completed in 2004 by medical researcher Susan Foster. Foster studied the brains of firefighters living in a station beneath a cell tower. Using SPECT brain scan technology, Foster found brain damage in all the firefighters. This result of this study could be extrapolated as directly relevant to a child's exposure in the classroom. Since that study, fire stations are now exempt from the placement of cell antennas for health reasons. Many students are in classrooms located just a few feet from cell towers on school grounds. The assistant principal at Beaumont School in Portland, Northeast Portland, said that immediately after the installation of the cell tower, children became noticeably jumpier. How could OHA make a determination when no measurements of exposure levels were taken in classrooms? The final draft of the OHA review poses a great threat to Oregon's children and needs to be retracted and replaced with the suppressed first draft. Public health must take priority.
Finish up shortly, please.
Public health must take priority to commercial and political interests. Thank you.
Thank you. Turn to Dan Forbes. Dan Forbes. Okay. We'll move on and we'll try to come back. Dan Forbes, we'll move to Zena Carmel Jessup.
Hello, thank you. I won't be able to use my camera, but can you hear me?
Yes, we can.
Okay. According to the Public Health Information Request, the Oregon Health Authority circulated the American Academy of Pediatrics recommendations to reduce wireless exposure among themselves when discussing their research review, but then omitted the fact that AAP had made the recommendation to reduce wireless exposure in the resources sent to the public. Why were the recommendations of our nation's largest group of pediatricians omitted? The AAP has sent several letters to the government calling for an update to the FCC limits because the safety limits we have do not account for the vulnerability of children's developing brains and bodies. Both the California and Connecticut Departments of Public Health recommend reducing radio frequency exposures to children's brains. The Maryland State Children's Environmental Health and Protection Advisory Council issued first ever state recommendations that recommends you should reduce wireless exposure in schools by providing wired rather than wireless internet connections. The New Jersey Education Association published an article, Minimize Health Risks from Electronic Devices. Remember when they said that low lead exposure could not harm? Remember when it seemed impossible to imagine replacing all the leaded water pipes? But we do it. Published research shows wireless damages memory both in rats and in teens and children. How many IQ points are an acceptable amount for a kindergartner to lose from daily Wi-Fi exposure? Due to the lack of awareness, the current disparities paired with the inequities of our healthcare system will create the perfect storm, harming our most vulnerable children. The Oregon Health Authority downplays the science. Their flawed report will be used in states nationwide as proof of no harm, despite its clear scientific shortcomings. As the oversight body, you must investigate this and ensure that a complete evaluation of the scientific research has been done to protect children from what scientists are calling a new form of environmental pollution. Thank you very much.
Thank you very much. We'll go, is Evbo here? Evbo? Okay. We'll
Hello,
go.
can you hear me?
Yes, please, go ahead.
Okay. My name is Eva, and I have OHP, and I have severe electromagnetic hypersensitivity, which has been determined by judges and doctors. And I have had problems using my OHP because of it. I would like for you to make it a policy that doctors need to leave their cell phones with somebody else, even if they're on call, and also that there be a doctor within the IHN system that recognizes and knows how to diagnose electromagnetic hypersensitivity. I also would like to suggest that preventative measures be taken in policy where when children and people have different ailments, that they suggest that they keep their wireless off and go hardwired in their homes. Phones have been shown to be over the limits, and other devices have been shown to be over even the federal safety limits. So the seriousness of electromagnetic radiation poisoning and injury needs to be taken seriously in OHA and OHP and IHN. Thank you. Did you hear me okay? Hello?
Yes, we did.
Dr. Bangsberg, are you there?
Sorry,
We may have lost him.
I was on mute. So we thank you for your comments. We also had Dan Forbes on the list. Dan, would you like to provide your comment?
Yeah, hi. Can you folks hear me?
Yes.
Hello?
Yes, we can hear you fine.
Great. Ms. Gomez, Mr. Kramer, welcome to the board. I'll get you a copy of my statement. So I read in the newspaper over the weekend, quote, if someone powerful makes an obviously false public statement and you publicly accept it to be true, then he knows that he can easily control you. That's part of what this is all about, the reaction to the Oregon Health Authority wireless risk assessment. And I say this in light of a hearing that the State Senate Committee on Education will be holding on this matter in September. That's already scheduled. This report was essentially the product of one man, its lead author. OHA lists reviewers on page 2, but the main one, Dr. Dean Seilinger, OHA tells me, only did his review a month after the report was completed, tied up in a bow and done. The other reviewer with the academic credentials to do the job, Dr. Diane Nago, also did her review after it was done. And so this lead author went about writing a report according to his own lights. And what he did was essentially delete page after page of first draft statements produced findings of increased evidence of harm from radio frequency radiation written in the first draft. He just crossed them out, flushed them down the memory hole. That's not how science is done. Such statements as, quote, all the studies that investigated the outcomes of health and symptoms of ill health found that exposure negatively impacted health. And all the studies that looked at reproductive harms found exposure led to harm. This gentleman also withheld this first draft from a public records request. That's taken seriously here in Oregon. That's a crime punishable by up to a year in jail. If Director Pat Allen is not going to do anything about this, I quote emails in my Washington Spectator article from the lead author.
Please.
And finally, I would urge the board to put this on their agenda. Complete your oversight responsibilities as mandated by the state law that brought the board into being. Thank you
Very much for your comment. We also have written comments from two people, Flora Cecily from Portland, Oregon, and I will read their comments. I am from Latin America, very familiar with government corruption, the way money infiltrates and protects the powerful, exactly why my family came to the United States. Imagine my horror as I watched something meant to protect our children completely and fraudulently betray public trust. By deceitful language implying studies pointing to harm did not cause harm, by withholding drafts that reported the truth and choosing to lie, the Oregon Health Authority has lost all credibility, and those who participate in this cover-up are guilty of scientific misconduct. I did not start out believing wireless radiation causes harm. The one fact that convinced me that seeing that insurance companies across the board include exclusionary clauses making any damage from wireless radiation exempt from coverage. As more reports of illness and death from the impact of the EMF, it is inexplicably that they choose to flagrantly manipulate a report. Even if this body doesn't care about sickening our children, one would think that it would care how lawsuits will bankrupt the state. Short-sighted, corrupt, lazy, and incompetent, the Oregon Health Authority should be investigated, the report retracted, and resubmitted in accordance to the scientific protocols of its own work withheld. And one more written comment by Uloma Igare Uche. And it states, the Environmental Working Group is a nonprofit research advocacy organization with headquarters in DC, and has analyzed public scientific literature on the human health effects of exposure to radio frequency radiation emitted from wireless devices. In 2020, Senate Bill 283 was passed, mandating the OHA to review studies of RFR exposures, especially in schools. In December 2020, the OHA reported on its comprehensive review of human epidemiologic studies of RFR exposures, included that in school settings, it is not associated with adverse effects. However, that report makes it clear that no comprehensive and systematic review of relevant RFR literature was conducted. Relevant epidemiologic studies, as well as in vitro and animal studies that have provided substantial evidence of adverse effects associated with RFR exposure, were admitted without scientific justification. It is worth noting that human health risk assessment has always relied on the findings from both animal toxicology and epidemiology studies to provide health-based guidelines for public health protection, and this approach has always been used by public health agencies, National Academy of Sciences, and the WHO. In addition, the report also omitted references from the 2001 classification of RFR as a class 2B carcinogen, as well as recommendations from public health agencies, such as the California Department of Public Health, the Maryland Commission on Children's Environmental Health, and other scientific groups. Contrary to the mandate in Senate Bill 283 that required including only independently funded studies, the report showed that industry-funded research studies, which reported no evidence that are associated with RFR exposure, were included in the review. Here, the external working group urges Oregon Health Authority to conduct a more comprehensive, systematic evaluation of RFR studies and update its report to reflect the extensive evidence of adverse effects associated with RFR exposure. Submitted on behalf of the Environmental Working Group. Thank you very much. I want to just appreciate people for their public comment, both oral and written. We've also received correspondence from individuals as well, and I want to recognize that while we have not not responded to each individual statement. Everyone has been received. I've read the report. I've read each individual statement, and we take your testimony seriously. And we'll follow up with the OHA staff and take your comments and public testimonies into careful consideration. So thank you again. Oh, we
And
have
Chair
one more.
Bainsberg,
We have one more YouTube.
yeah, of the video.
Yes, from Dan Ford, or not from.
University. I am a senior lecturer and member of the Department of Physics of Ariel University in Israel. My specialty is dielectric spectroscopy, i.e. the study with high frequency radio waves, those similar to what is proposed for 5G and also networks. The article database used by the report, Wireless Technology Health Risk Report, was extremely small and not representative of what the scientific community actually says. A noted expert like Dr. Christopher Portier stated in an expert opinion that, in my opinion, RF exposure probably causes gliomas and neuromas, and given the human, animal, and experimental evidence, I assert that, to a reasonable degree of scientific certainty, the probability that RF exposure causes gliomas and neuromas is high. A review done by Kostov et al., published in Toxicology Letters in 2020, summarizing basically over 5,000 articles. Their conclusion is that there are indeed adverse effects and that they are indeed worrying. And in fact, to quote from them, they state, superimposing 5G radiation on an already embedded toxic wireless radiation environment will exacerbate the adverse health effects shown to exist. Far more research and testing of potential 5G health effects under real-life conditions is required before further rollout can be justified. None of these reviews have been incorporated into the Wireless Technology Health Risk Report produced by the Oregon Health Authority. And I consider that it is wholly unrepresentative of the current science of exposure and the worries that we in the scientific community feel exist.
Thank you very much. So that ends public comment. Again, thank you all for your public comment. We will review this with the Oregon Health Authority. That kind of is a close to our July meeting of the Oregon Health Policy Board. I would like to remind you of an upcoming webinar on July 13th at 8 a.m. about the committee membership project. This is a request to explore the status of committees and to strengthen diversity, equity, and inclusion of our members and prospective members on the board and associated committees. Our next Oregon Health Policy Board meeting will be Tuesday, August 3rd. Look forward to seeing you then. Once again, thank you for a very good meeting, discussion, and public comment. Please enjoy the rest of your day.
Thank you.